So, Dr. Faith, over to you.
Okay.
Hello, Chief Okopi. Good evening. Good evening, everyone. Hello.
Good evening. Good evening.
I don't know, am I supposed to start today? My next session is section G, the last part of it.
So sorry, please. Can I do the presentation? I'm on call today and I have like 3 patients I've not reviewed. So if I can just get done with this presentation so I can run off to the emergency, please.
Okay. Well, I don't know. Because I thought my
Yes,
own.
yes, please, Obasi, what number are you taking, please? Okay, Augustine, okay, yeah, do your presentation, please.
Okay.
We have a presentation on pericardial disease. You can share your slides here.
Okay, thank you. Okay, so can I get started? Can I start?
Yes, please.
Okay, so good evening to the house. This evening I'll be doing a presentation on overview of pericardial disease under the following outline. So let me time myself under the following outline. Okay. So starting with the anatomy of the pericardium. The pericardium is composed of the viscera and the parietal pericardium. And for the visceral pericardium, it's a monolayer of mesothelial cells. It also has a collagen, elastin fibers, which is adherent to the epicardial surface of the heart, and also the visceral pericardium also reflects back near the origin of the great vessels and is continuous with and then forms the inner layer of the parietal pericardium. So for the outer part, which is the parietal pericardium, it's a fibrous parietal layer, which is about 2 millimeters in thickness and surrounds most of the heart. And also apart from that, it's largely acellular and contains collagen and elastin fibers, with collagen being the major structural component. So the space between the viscera and the parietal pericardium has the pericardial fluid, which is usually within 20 to 50 mils. Okay, this is just a pictorial view. Okay, as we can see it, the labeled already, the viscera is actually closely adjoined to the epicardiac area of the heart, and then the parietal is the outer part. And also looking at this other picture, moving from the inside of the heart is the endocardium, then followed by the myocardium, the epicardium, which has a close proximity with the visceral pericardium, and also we have the parietal pericardium. Okay, so the parietal pericardium has a ligamentous attachment, and so it is attached to the diaphragm, the sternum, and also the costal cartilage. And this attachment keeps the heart in a fixed position within the thoracic cavity. And the only known cardiovascular structure associated with the pericardium are the phrenic nerves, which are enveloped in the parietal pericardium. Okay, so for the physiology, it has a restraining effect on cardiac volume. So this reflects the mechanical property of the pericardium. And also the parietal pericardium has a tensile strength, which is similar to that of a rubber. So at low stress, it can be elastic. And as the stretch increases, however, the tissue abruptly becomes stiff and resistant to further stretch. So the pressure-volume relationship of the pericardiac sac, which parallels with the property of isolated parietal pericardial tissue. Okay, so looking at the function, the pericardium provides a barrier to infection, prevent the heart from getting easily infected, and also the lubrication provides some form of lubrication within the viscera and the parietal layer. The pericardium is well innervated with mechanoreceptors, chemoreceptors, and phrenic nerve receptors that participate in reflexes arising from the pericardium or the epicardium, and they also mediate transmission of pericardiac pain. And this is mediated by secretion of prostaglandin, basically. Okay, so talking about acute pericarditis now. Acute pericarditis is the inflammation of the pericardium, and it is characterized by pericardiac chest pain, pericardiac frictional rub, and serial ECG changes. The commonest cause of acute pericarditis is said to be idiopathic, and efforts were made at some point in time to look at the possibility of getting a culture, because also apart from the viral cause, it's also assumed that apart from the idiopathic cause, it's also assumed that the viral organism also plays a significant role in causing acute pericarditis. But however, it is said that the cost of getting this procedure done to culture for the virus is a bit expensive, and then at the end of the day, you tend to have a low yield, and it also doesn't have a significant impact on patient management, basically. So talking about the epidemiology of acute pericarditis, most of them are undiagnosed, and then during autopsy, the frequency is approximately about 1%. And for most patients that come into the emergency unit, acute pericarditis is said to account for 5% of non-ischemic chest pain. And then the fraction of all acute cases accounted for by idiopathic compared to those with specific cause is also uncertain, and then is basically influenced by the demographic and the variation in viral infection. Okay, so these are a number of causes of acute pericarditis, usually idiopathic, and it could be infectious. And then under the infectious group, we have the virus, and then a number of them are listed there. And also checked up on the new disease with us now, COVID, which is also said to be able to cause acute pericarditis, but the incidence is said to be very, very low. So apart from the viral infection, we also have the bacterial infection, the pneumococcal, staph, strep, and the rest of them. Then fungal infection can also cause pericarditis. Protozoan can also cause pericarditis. So we have connective tissue disease, and then chief among these are the systemic lupus erythematosus, rheumatoid arthritis, scleroderma, and then Sjogren's syndrome. Drugs are also known to cause acute pericarditis. So we have procainamide, hydralazine, and the others are listed there. And after myocardial infarction, particularly when you have a transmural form of infarction, in the early stage, it's also possible to have acute pericarditis, and also much later, where we have a Dressler syndrome, usually about 2 to 3 weeks later, which is an immune-mediated process. Okay. And also malignancy, cancers can also cause, so I want to change to a pointer so I could be easy to point, okay? So we also have malignancy, which a number of them are listed here, and other miscellaneous causes of pericarditis, acute pericarditis. So for the classification, they're classified into acute pericarditis, which is usually less than 6 weeks. And then for the subtype under the acute, we have the fibrinous. So they tend to have this fibrinous exudate, and it's also referred to as a dry form of pericarditis, because they tend not to actually have so much pericardiac fluid there. So they tend to have a fibrinous exudate with an inflammatory reaction, which involves the viscera and the pericardium. And the epicardium is also involved, and this also helps to help us have the changes that are noticed on the ECG. We also have the effusive type. So in addition to the fibrous inflammation, there is significant fluid exudation. So this tends to produce more fluid. And the pericardial fluid may be serous, sanguineous, which is stated there, and even sometimes could be hemorrhagic and may even be purulent. Okay, so when we have acute pericarditis coming up within 6 weeks to 6 months, The subtypes are also here, the effusive, constrictive, and the deconstrictive. And then for more than 6 months, we have the chronic pericarditis, okay? So irrespective of looking at the pathogenesis, now irrespective of what the etiology is, which were mentioned earlier on, we tend to actually have acute inflammation because the etiologies will actually cause insult to the pericardium, and there will be infiltration of inflammatory responses. It tends to actually kickstart a form of acute inflammation, and there will be infiltration of the polymorphonuclear leukocytes, and you also tend to have a perivascular vascularization, okay? And at the end of the day, pericarditis is established, and then there's some form of swellings, which I'll also show much later. Then, so because of the inflammation and the swelling that occurs from inflammation, there could be a restriction in venous filling of the ventricles, basically. And over time, may also impede relaxation of the heart. And bearing in mind that some cytokines are released, prostaglandin is released, which could also mediate pain in this group of patients. So looking at this other picture on the side, just trying to actually cut it and then make it a bit more visible for us. The shaded line here shows the visceral pericardium. Okay, this is the cardiac myocyte from the picture. The next line, the shaded one, has the pericardium. Then we have the visceral pericardium. Then this is the pericardiac space, okay, in between the viscera and the pericardia, okay, and this is the pericardia, okay. This is what we find in the normal pericardiac sac and the heart, as it were. So when there's inflammation, you could have inflammation of, like here now, inflammation around the pericardial area, so there will be much of swelling of the pericardial pericardium, thus narrowing the pericardiac space, as we can see here. So in this type of pericarditis now, where we have the fibrinous type, also referred to as a dry pericarditis, they're just narrowing of space, but not really effusive, not producing so much fluid there. However, when we have production of fluid, as we can see from this last diagram now, the fluid tends to actually even widen the space between the visceral pericardium and also the pericardial pericardium, basically, okay? So this is just showing some microcellular level where you have prostaglandin and it intimidates the fever and pain which you see. So still on the pathogenesis, so pericardial physiology includes 3 main functions. It has a mechanical function, okay? So the pericardium promotes cardiac efficiency by limiting acute cardiac dilatation, maintaining the ventricular compliance with preservation of the Starling curve, and then distributing hydrostatic forces. The pericardium also creates a closed chamber with subatmospheric pressure. Talking about the mechanical function, and looking at the membranous function, the pericardium shields the heart from by reducing external friction and acts as a barrier against extension of infection and malignancy. And like I said initially, the ligamentous attachment to the diaphragm and other adjoining structures helps to keep the heart in place in the mediastinum, okay? So in acute pericarditis, the pericardium is acutely inflamed. I think I've explained those ones. Let me just pick the prominent things with the picture I showed earlier on. So you can also have the fluid being hemorrhagic effusion, and there are instances where you have a granulomatous pericarditis, which occurs with tuberculosis. Fungal infection can also give that kind of presentation. And also occasionally you can have a rheumatoid arthritis and sarcoidosis. So there's also recurrent pericarditis, patient that has actually had some form of treatment earlier on, and the patient is actually coming down again with pericarditis. So recurrent pericarditis tends to occur when symptoms of acute pericarditis returns after patient has been symptom free for about 4 to 6 weeks. And the innate system tends to play a role in this, and particularly in patients who have underlying acute inflammatory or autoimmune disorders. So there's an inflammatory response to the innate immune system, and will actually trigger an episode of a recurrent epicarditis. So we also have a uremic pericarditis, which results from inflammation of the viscera and the pericardial layer by toxins, basically, okay? So looking at the anatomical forms of the pericarditis, we have this serous pericarditis. So we have serous inflammation, which we have a serum inflammation, and exudates are characteristically produced by non-infectious inflammation such as rheumatic fever, systemic lupus, scleroderma, tumors, and uremia. Okay, and an infection in the tissue contagious to the pericardium, can also give rise to serous pericardium. So bacterial pleuritis, these are the happenings within the lungs. Okay, may cause sufficient irritation of the pericardiac serosa to cause sterile serous effusion, which may progress to frank suppurative reaction. And looking at the morphology, the inflammatory reactions in the epicardiac and the pericardiac surfaces with scanty numbers of polymorphonuclear cells, lymphocytes, and macrophages. And the volume of fluid is not usually large. It could have within the range of 50 to 200 ml, and they tend to slowly accumulate. And they also tend to find the lymphocytes, which are a bit predominant, particularly in chronic pericarditis. So we also have the fibrinous and the serofibrinous pericarditis. The anatomic form are the most frequent type of pericarditis, and it's composed of serous fluid mixed with fibrinous. Okay, so the common causes of this is acute myocardial infarction. You have the Dressler syndrome. Uremia can also contribute. Radiation, and also some of the connective tissue diseases can also contribute. So for the morphology, in fibrinous pericarditis, like I said initially, the surface is dry with fine granular roughening, and then serofibrinous pericarditis has an increased inflammatory process, and which induces production of fluid which are thicker, and which is said to be yellow and cloudy due to the presence of leukocyte, erythrocyte, and also fibrin. And over time, there may be resolution of the exudate, or it may become organized. Okay. Then, so development of the loud pericardial frictional rub, which is usually found in patients with pericarditis, is the most striking characteristic of fibrinous pericarditis. And they also tend to have pain, systemic febrile illness, and then signs suggestive of heart failure may be present. Okay, so we also have the purulent and the suppurative pericarditis, and this denotes invasion of the pericardial space by infective organisms, which may reach the pericardial cavity by several routes. So it could happen by direct extension from neighboring inflammation. For a patient who have empyema, for example, lobar pneumonia, the close proximity to the heart, to the pericardium, can actually allow infection of the pericardium. Then we also have hematogenous spread. Okay, we also have lymphatic extension and direct introduction of microorganism during cardiotomy. And the patient with immunosuppression also tend to be susceptible to infection by all of these pathways. Okay, so the clinical finding in the active phase are essential, and then as the same as the fibrinous pericarditis, but signs of systemic infection are usually marked depending on what infective agent is at play. There could be fever, chills and rigor, and the rest of them. Okay, so we also have the hemorrhagic pericarditis. For the hemorrhagic pericarditis, an exudate composed of blood mixed with fibrinous or suppurative effusion is most commonly caused by malignant neoplastic involvement of the pericardiac space. So in hemorrhagic pericarditis may also be found in bacterial infections, and with underlying bleeding diastasis and tuberculosis. Can also be found during cardiac surgery, and the clinical significance is similar to the spectrum we have with the fibrinous or suppurative. We also have the caseous pericarditis, which is cassation within the pericardiac space, and until proven otherwise, tuberculosis is the culprit for caseous pericarditis, and a number of times you could also have a fungal infection to actually give you a similar presentation. So pericardiac involvement occur by direct spread from the tuberculous foci within the tracheobronchial nodes. Caseous pericarditis is rare, but is the most frequent antecedent of disabling fibrocalcific, and can also lead to chronic constrictive pericarditis. We also have the chronic or healed pericarditis, the adhesive mediastinal pericarditis. So this form of pericardial fibrosis may follow a suppurative or caseous pericarditis, a patient that had a previous cardiac surgery, exposure to radiation, and the pericardial space is obliterated, and adherence to the external aspect of the pericardial layer to surrounding structure, producing a great strain on cardiac function. So with each systolic contraction, the heart is pulling not just against the parietal pericardium, but also the adjoining structures to the pericardium, basically. And also talk about, so over time, it will actually lead to constrictive pericarditis. So in constrictive pericarditis, the heart is like a stiff, you have like a stiff pericardium. So the heart is encased in a dense fibrous or fibrocalcific scar that limits the diastolic expansion and seriously restrict cardiac output. For the morphology, the exudate you find there ranges from a thin to a creamy pus of up to 400 to 500 mils in volume, and the serosal surface are reddened, look granular, coated with the exudate, and then microscopically there's an acute inflammatory reaction which may extend into surrounding tissue, giving us the mediastinal pericarditis. And then there could be organization. Okay, organization is the usual outcome, and resolution is not very common, and then this can be complicated with a constrictive pericarditis. So moving to clinical features now. So for the clinical features, basically, like I said initially, a lot of cytokines, prostaglandin are reduced, which can mediate fever in them. And depending on what the primary etiology is, for a patient who has tuberculosis or who have bacteria form of infection, you can also explain why they have fever. And for patients who tend to have viral cause most of the time, it's also important to get history of maybe upper respiratory tract infection 3 weeks or thereabout before the onset of these symptoms. And because of the cytokine release, I also explain why you have myalgia in them. And they tend to have this tripod position, which makes them feel better and tends to relieve the chest pain which they have. Okay, so over time with progression, if nothing is done, a patient may classically have signs of right heart failure, which we're going to talk about much later, which you could have in tamponade, we could have in constrictive pericarditis, basically. Okay, so looking at the chest pain, which seems to be the main complaint of the patient, it is said to be present in about 85 to 90% of patients who have acute pericarditis. It is usually present in the acute infectious type, and then in many of the forms presumed to be related to hypersensitivity or autoimmune. Pain is often absent in slowly developing tuberculosis or post-radiation, neoplastic and uremic pericarditis. And the pain of acute pericarditis is often severe, retrosternal, left pericardial, refer to the pain. And this kind of presentation can actually mimic a patient who has acute myocardial infarction, basically. But often the pain is also maybe pyretic. Okay, they have fever, dyspnea, which I think we've talked about. So for the examination, the classical pericardial frictional rub is easily recognized, and it's said to be pathognomic of acute pericarditis, which is found in only about 33% of patients. And the pericardial rub consists of 3 components, which could be picked during the ventricular systole, early diastolic filling, and atrial contraction. And the way it sounds, it is likened to the sound made when walking on a crunchy snow. Though I haven't walked on snow before, so not too sure what they're talking about, but at least maybe from learning from our teachers, basically. So, so the rub is usually loudest at the lower left sternal border and best heard when the patient leans forward. It is often dynamic, disappearing and returning over short interval. And the sensitivity is not that very high. Okay, so to make assessment of pericarditis, we have acute pericarditis, we have incessant pericarditis, there's recurrent and chronic pericarditis. So to make assessment of acute pericarditis, there's inflammatory pericardial syndrome to be diagnosed with at least 2 of the following criteria. So patient should have a pericarditic chest pain, pericardiac rub by you pick, that's one of the signs. Then when the ECG is done, mean widespread ST segment elevation or PR depression on ECG. And when echo is also done, you correctly pick a pericardiac effusion. Is that a new pericardiac effusion or a worsening pericardiac effusion? So any 2 of these. So, but there are also other additional supporting findings, like having elevated markers of inflammation, the CRP, the ESR, and elevated WBC, and also your CT and the cardiac CMR may also show pericardiac inflammation. So for incessant pericarditis, is pericarditis lasting for more than 4 to 6 weeks, but less than 3 months without remission, okay? Then we also have the recurrent pericarditis, and the recurrence of pericarditis after a documented first episode of acute pericarditis, and patient is symptom-free for an interval of 4 to 6 weeks or longer, okay, before coming down with another episode of pericarditis. Then we also have chronic pericarditis, which usually lasts more than 3 months. Okay, there are other closed differentials that can also confuse making that diagnosis, basically. So going to investigation. So ECG is recommended, which is a class 1 recommendation. Also the transthoracic echocardiography is also another class 1 recommendation. Chest X-ray is also part of the class 1 recommendation, and also the assessment of markers of inflammation, your CRP, cardiac injury, and then can also help us to look at that possibility, to rule out possibility of myocardial infarction if we are not so certain. So looking at the ECG, just click on one ECG. So you tend to actually have this diffuse ST segment elevation, and the ST segment elevation is in all the leads except AVR and often V1, may or may not for the V1. Then the PR segment depression is also common, and it can occur without ST segment elevation. Some patients may just have a PR segment. You may not possibly find the ST segment elevation, and it may be the initial or the only manifestation of acute pericarditis on ECG. In some cases, the ECG findings tend to revert to normal over a period of days to weeks. And in others, the ST segment elevated segment passes through the isoelectric points and then progresses to ST segment depression and T-wave inversion. And in a number of people, these changes may persist for weeks or for months. This is just ECG showing the patient with this is ST segment elevation, there's PR segment depression, likewise in the 2. Okay, in AVR, it is rather okay. It's the PR segment is elevated here, and the ST segment is depressed. And we're looking at V2 to like V6 or thereabout. There's ST segment elevation there. Okay, so stages of ECG changes. Stage 1 accompanies the onset of acute pain and is a hallmark of acute pericarditis. So ECG changes include diffuse concave upward ST elevation, except in AVR, which has the opposite as we showed, and V1, which is said to be usually depressed. T waves are upright in the leads with ST elevation, and the PR segment deviates to opposite of the P wave polarity. So the stage 2 occurs days later, where we have a returning of the ST segment to baseline, followed by flattening of the T wave. And in the stage 3, we have the T wave becoming inverted without T waves. And then stage 4, the T wave returns to normal, or inversion persists in chronic inflammation. I think we talked about most of this earlier on the CRP, in particular the high sensitivity CRP, which is elevated in about maybe 75% of patients with acute pericarditis. And in most cases, the high sensitivity CRP normalizes within 1 week. and in almost all cases by 4 weeks after initial elevation. And the increased high sensitivity CRP is independently associated with recurrent symptoms. Patients who tend to have a recurrent pericarditis, and the serial high sensitivity CRP determination to be used to determine disease activity and aid in determining the duration of therapy. Okay, so chest X-ray can also be done, but chest X-ray will be normal in uncomplicated acute pericarditis. And then the echocardiogram is also another important investigation modality. I think I have a slide on, okay, which I think I have a slide on that much later. And the essence of that is just to show if there's a fusion or not. And the CT, the MRI is also very important just to look out for pericardial thickening. And MRI provides evidence of active inflammation based on increased gadolinium uptake. Okay, so this is the chest X-ray of the patient. Apart from having pericarditis, also has a pericardial effusion, tends to have this water bottle heart. Okay, this is also another echo diagram which shows a thickening around the pericardium area here, and also some mild effusion here, and the mild collapse of the right atrium, as you can see. Okay. So these are other investigations that can be done. I think we've talked about them to save some time. So for treatment, so hospital admission is recommended for high risk patient with acute pericarditis, and for high risk, the risk would be patients who have systemic autoimmune disease, patients who have viral or bacterial infection, patients who have had cardiac surgery, patients that have had transmural MI, uremia, or dialysis. Okay, then outpatient management is also recommended for low risk patients, and then response to evaluation of response to anti-inflammatory therapy is also recommended after 1 week. Just before going further, a number of prognosis for patients who have pericarditis: poor prognosis with high temperature more than 38, subacute disease course, patient with a large pericardial effusion or who has a tamponading physiology, immunosuppression, and the rest of them. Okay, so so for the treatment, aspirin and NSAID are recommended as the first line for acute pericarditis. And it's also important to put in mind gastroprotection, so which means you need to put the patient on PPI also. Colchicine is also recommended as first line in a patient with acute pericarditis, but as an adjunct to either aspirin or NSAID. And then the serum CRP should also be considered to guide the treatment length and then assess the response to therapy, which is a class 2A recommendation. Low-dose corticosteroid should be considered for acute pericarditis in cases of a contraindication or failure to use aspirin or NSAID or colchicine, and when an infectious cause has been excluded, or when there is a specific indication such as autoimmune disease. And there's also need for exercise restriction for non-athletes. There's need to actually restrict exercise when the patient has acute pericarditis until there's resolution of those symptoms. And the CRP and the ECG and echo can also be used to monitor the patient as such. And also for athletes, there should be restriction also. They could monitor with the CRP, ECG for at least 3 months. So steroid is not recommended as a first-line therapy for acute pericarditis. It is not recommended, okay? So for patients with recurrent pericarditis, aspirin and NSAID are the mainstay of the treatment and are recommended at full doses and if tolerated until complete symptoms resolves. So colchicine is also given, which is supposed to be an adjunct to aspirin and can go for as long as 6 months. For as long as 6 months, then CRP dosage should also be considered to guide the treatment duration and assessment of response therapy. And after the CRP normalizes, a gradual tapering of the therapy should be considered, tailored to symptoms, and then CRP stopping at single class of drug at a time. A number of the other ones are, I think, mixture of a class 2A and then 1A, and the exercise restriction is also part of what should be done for patients who have recurrent pericarditis. Let me just skip this. So acute idiopathic pericarditis is self-limiting without disease. Sorry, acute idiopathic pericarditis is self-limited disease without significant complication or recurrence in 70 to 90% of patients, and the NSAID should be initiated because of its excellent safety profile. For the ibuprofen, we go as high as 600 to 800 milligram orally 3 times a day. Then salicylic acid can also be given up to 2 to 4 grams daily in divided doses. So like I said initially, a proton pump inhibitor should also be given to this patient for gastric protection. Colchicine involves initial response when used in conjunction with NSAID. Okay, so patients who respond poorly to NSAID are typically treated with steroid. However, their use appear to promote recurrence, and moreover, the previous recommendation of short course of high-dose corticosteroid with rapid tapering seems to especially increase recurrence. Okay, so the complications of acute pericarditis could have effusion, tamponade, which we're still discussing. So for the next type of pericardial disease, now we have the pericardial effusion, which is the presence of an abnormal amount of fluid and or abnormal character of fluid in the pericardial space. Increased production of the pericardial fluid from inflammation, and then there's decreased resorption due to general increase in systemic venous pressure, or as a result of heart failure or pulmonary hypertension. So TB is the dominant cause in developing country, and in the developed world, the cause is said to be more of an idiopathic, and other causes that have been highlighted are cancer, infection, and infection basically. So for classification of pericardial effusion, based on the onset, it could be acute, subacute, or chronic, based on the size, less than 10 millimeter, moderate 10 to 20, and large is more than 20. And based on the distribution, is this circumferential, is loculated, and also the constituent, the composition of the fluid itself, whether it's transudate or exudate. So the clinical presentation of pericardial effusion varies according to the size, the speed of accumulation of the fluid, and the size of the pericardial fluid. So for a rapid accumulation of fluid can actually give symptoms, and for those who have a slow collection of those fluid, it gives the pericardium ample chance to be able to cope with these with a large volume. So patient could have dyspnea on exertion, they could have autopnea, chest pain could also be there. So what are the compression effects of having pericardial effusion? So because of the pressure on the diaphragm, patient could feel nauseated. On the esophagus, they could have some dysphagia. On the recurrent laryngeal nerves, they could be hoarseness, and on the phrenic nerve, they could have hiccups, and they have a number of other non-specific symptoms which they could present with. Okay, then the findings of pericardial effusion may be normal, particularly when you have a mild effusion. Okay, and for those who now tend to have a collapse of the right ventricle or the right atrium, then signs of tamponade will tend to be obvious in those group of patients, where they tend to have a neck vein distension with elevated JVP, pulsus paradoxus, which is defined as a reduction in systolic blood pressure during inspiration more than 10 millimeters of mercury, which can also be present in a number of other conditions, which we mentioned in passing. And there's diminished heart sound on cardiac auscultation. Okay, so for diagnosis of pericardial effusion, the transthoracic echocardiography is recommended, which is a class 1 recommendation. Chest X-ray is also recommended with a suspicion of pericardial effusion and pleural involvement. The CRP is also important for patients who have a pericardial effusion to help monitor them. The CT or the magnetic resonance imaging could also be considered in suspected cases of loculated pericardial effusion, pericardial thickening, and the masses as well as associated chest abnormalities. Okay, so for the management of pericardial effusion, we need to assess its size, assess the hemodynamic importance in discussing the tamponade, and to assess the possible associated diseases that might have led to that point. So you treat the underlying cause. If the patient has had features of pericarditis, that should also be taken into consideration. And then pericardiocentesis, if the patient is asymptomatic, a pericardectomy or pericardial window should be considered if fluid reaccumulates or effusion is loculated. So the guideline for treatment, it is recommended to target the therapy of pericardial effusion with respect to the etiology. Okay, then aspirin, NSAID, colchicine, and the treatment of pericarditis is recommended when pericardial effusion is associated with systemic inflammation. Pericardiocentesis or cardiac surgery is indicated for cardiac tamponade or symptomatic moderate to large pericardial effusion, not responsive to medical therapy, or for suspicion of unknown bacteria or neoplastic etiology. Okay, so to cardiac tamponade now, okay, is the accumulation of fluid in the pericardial space, okay, in a quantity which is sufficient to cause serious obstruction to the inflow of blood to the ventricles, okay, and results in cardiac tamponade. And this complication may be fatal if it is not recognized and promptly treated. And there are three common causes of cardiac tamponade, neoplastic diseases, idiopathic pericarditis, and renal failure. Okay, so tamponade may result from bleeding to the pericardiac space after cardiac surgery. It can be due to trauma, treatment of patient with acute pericarditis with anticoagulants. And then the three principal features of a tamponade can be found with the Beck's triad, where there's a drop in blood pressure. They tend to have hypotension. There's a soft or usually absent heart sound, and the JVP descent with a prominent X descent and absent Y, which I will explain. I think there's a picture to explain that, one or two slides from here. So there are both limitations to ventricular filling and the reduction in cardiac output. Okay, so let me just go here. Okay, so so this is just the heart, as it were, in a pool of fluid. Okay, the outer one is the pericardium. Okay, and the heart is the one inside there, and then this is a form of circumferential effusion. Okay, and this effusion tends to, when it becomes significant, usually when you have moderate to severe, it could actually start to put pressure on the chambers, like here around the right ventricle and then the right atrium, and could collapse. You could collapse the right ventricle or the right atrium here, basically. And to explain why we have prominent descent of X. So just to refresh our memory, the JVP, the A is for the atrial contraction, the C is for the closure of the tricuspid valve, and the V is infilling of that closed, on top of that closed tricuspid valve. So X is usually due to atrial relaxation. Okay, so the atrium is usually relaxed. Even in tamponade, it should do some form of relax, though it could be steep, and so you tend to have the X moving really moving fast downward. Okay, so you tend to have compression of the fluid, the cardiac fluid. Okay, compresses the right ventricle, and then because of our Y, to find Y is usually due to opening of the tricuspid valve. Okay, so even if the tricuspid valve wants to open, as it were, okay, the content in the right atrium will not be able to fill in because there is going to be collapse of the right ventricle. So with the collapse of the right ventricle, you're going to find little or no Y descent at all. So the prominent thing would be your JVP, which is 1, and then also the prominent X. So only the X that you possibly see due to relaxation of the atrium. Okay, so let me just go back a little. Okay, yeah. So for the etiology, most of what we cause pericarditis are culpable in tamponade air. And for the pathophysiology, so we tend to have accumulation of the fluid. So formation of the effusion is a component of inflammatory response. Okay, could have infectious process, inflammatory process, neoplastic process that will lead to formation of fluid within the pericardium. And another reason why you can also have fluid within that pericardium could be due to lymphomas occasionally, which occasionally causes effusion in association with enlarged mediastinal lymph nodes by obstructing lymph drainage. Okay, so the pathophysiology of effusion in situations with no obvious inflammation, such as uremia, are said to be poorly understood. Okay, then so this picture, which I tried to explain earlier on. So clinically, the most critical point occurs when the effusion reduces the volume of the cardiac chamber, which I tried to show us, such that the cardiac output decline. So if there's compression of the right ventricle, for example, and to the effusion, that means a little or no blood is able to go through the pulmonary artery to enter the pulmonary vasculature and to come into the left atrium and also the left ventricle. So invariably, you tend to have reduced cardiac output, and then the little quantity that goes will definitely not be enough to meet the metabolic requirements of the body. Okay, so the determinants of the hemodynamic consequences of an effusion are the pressure in the pericardiac sac and then the inability of the heart to compensate. Okay, so the pressure in turn depends on the amount of fluid and the pericardial pressure volume resistance, which I tried to explain earlier on. So the pericardium normally has little reserve volume, and as a result, relatively modest amounts of rapidly accumulating fluid, as little as 150 to 200 ml, once it's just rapidly accumulating, can have a major effect on cardiac function. Okay, and you can also have large, slowly accumulating effusion, and are often well tolerated, presumably because of the chronic changes in the pericardiac pressure volume resistance, which I described earlier. So because of the reduction in cardiac output, basically, okay, there's a form of compensatory stimulation of the sympathetic system. So the compensatory response of an effusion includes increased adrenergic stimulation, and there's a lowering of the parasympathetic, such that there's tachycardia, which tries to drive the little stroke volume you have and to possibly try and increase blood flow. And then there's increased contractility, and they can help to maintain cardiac output and blood pressure for just a period of time. Okay. However, eventually, cardiac output and blood pressure will decline as the process keeps worsening, because you're not feeling, there's no feeling for the left side of the heart, so there's might be nothing to push out much later. So a patient who cannot mount a normal adrenergic response, such as patient on taking beta blockers, are more susceptible to the effects of effusion. And in terminal tamponade, the pressure reflex with a paradoxical bradycardia may actually supervene. Okay, so I think I've talked about Posso's paradoxes. So the important clue to the presence of cardiac tamponade consists of a greater than normal 10 millimeter of mercury or more inspiratory decline in systolic arterial pressure. And then when severe, it may be detected by palpating weaknesses or disappearance of the arterial pulse during inspiration. But usually, this fig measurements of the systolic blood pressure during slow respiration is required. So I think I'll try to explain most of this so as to save our time. I think I'll try to explain. Okay, let me just read this. So respiratory distress increases the fluctuation in the intrathoracic pressure, which exaggerate the mechanism just described. Okay, so the right ventricular infarction may resemble cardiac tamponade, with hypotension, also have elevated jugular venous pressure and absence of the wide descent in the jugular venous pulse, and occasionally Posso's paradoxes. And Posso's paradoxes occurs not only in cardiac tamponade, but also in approximately a third of patients with constrictive pericarditis. So for okay, so it's much more prominent more in cardiac tamponade, but it can also be found in constrictive pericarditis, just about a third of them. And then the physical finding of is not pathognomic of pericardial disease because it may also be found in some cases of hypovolemic shock, acute or chronic obstructive airway, and pulmonary embolism. So for the examination, a complete physical examination of patient with pericardial effusion will provide clues to specific causes. And in pericardial effusion with that tamponade, the cardiovascular findings are usually normal as well. And especially when you have somebody who has a mild effusion, which is not causing a tamponading effect. However, if the effusion is large, okay, the cardiac impulse may be difficult to palpate and the heart sounds are muffled, okay. A frictional rub may of course be present, and then there's a tubular breath sound may be heard in the left axilla or base because of bronchial compression. This is referred to as, I think, Ewart sign. Ewart sign. I'm not sure of what pronunciation is actually correct. That's Ewart sign. Okay. Then you also have Beck's triad, which I talked about earlier on while you're examining your patient. Okay. So patients with tamponade appear uncomfortable with signs reflecting varying degree of reduced cardiac output and shock. You could notice that they could have tachypnea, they could be diaphoretic, they could over time have a good extremities cyanosis, and may ultimately move towards a part of the breast sensorium. So hypotension will reduce pulse pressure is usually present, although in the early stages, compensatory mechanism maintain the blood pressure, and some patients with subacute tamponade are hypertensive on initial evaluation, with a decline in blood pressure occurring after pericardial drainage. So the paradoxical cause is the rule, but it is important to be alert of situations in which it may be absent. Okay. So for investigation, the ECG, there's reduced voltage complex. You can find it reduced voltage complex, and is non-specific and can be caused by other conditions like emphysema, infiltrative diseases, pneumothorax. So on the ECG also, you could have electrical alternance where you have alternating, like looking at the T-wave, for example, now they have this alternate, the QRS, I mean, you have this alternating QRS, okay? And there are instances whereby you could also have, by extension, not just the QRS, the P-wave will have this kind of electrical alternancy T also, which shows that the effusion is really massive. So electrical alternance is specific, but relatively insensitive for large effusions. It is, so why do we have that alternating pattern on ECG? It is caused by the anterior posterior swinging of the heart in that massive river of effusion with each contraction, okay? So when pericarditis coexists, the usual finding on ECG may also be present. So this is an X-ray. And for this patient, there's a massive effusion here, and you tend to have this flask-like appearance, which you can see here. Okay, so for the echo, so the echographic technique remains the standard non-invasive method for detecting or detection of pericardial effusion and tamponade. And effusion appears as a lucent separation between the perimeter and the visceral pericardium for the entire cardiac cycle. And so as the fluid increases, it spreads anteriorly, laterally, and behind the left atrium, where its limit is demarcated by the visceral pericardial reflection. Okay, so depending on the size of the effusion, like I said initially, less than 10 is mild, 10 to 20 is moderate, and more than 20 is large. Okay, so because of the rapidity of accumulation is critical, the hemodynamic significance of an effusion does not always correlate closely with its size. However, tamponade does not usually occur without a circumferential effusion. So usually by the time you're having a tamponade, it's likely you have a circumferential effusion. However, loculated effusion can also cause tamponade, and you could find frog-like or shaggy-like appearance in the pericardial space, which could be seen on echocardiography, and they could suggest a presence of clots, chronic inflammation, neoplastic pericardiac processes ongoing. So CT and MRI are more precise than echocardiography in evaluating the pericardium itself. And tamponade is best considered as a spectrum of severity of cardiac compression with early diastolic collapse of the right ventricle. Could also have late indentation or collapse of the right atrium. There's exaggerated duration in the right ventricle and the left ventricle chamber size, and the interventricular septal shift during inspiration. Okay, so early diastolic collapse of the right ventricle and late diastolic collapse of the right atrium are reported to be sensitive and specific signs that appear relatively early during tamponade, and both occur when the pericardial pressure transiently exceed the intracavitary pressure, which is the pressure outside is more than what you have inside the heart. So it can actually cause a collapse, basically. So the distension of the cava vessel that does not diminish with inspiration is also a good sign, because you are trying to actually have your inflow into the heart, but the chambers are compressed, so the distension of the cava vessels will not diminish. And the Doppler velocity recording demonstrates exaggerated respiratory variation in right and left-sided venous and valvular flow, with inspiratory increase on the right and then decrease on the left. So with the MRI and the CT, so MRI with gadolinium uptake more specifically identifies inflammation, and then clues to the nature of the pericardiac fluid can be gained from CT attenuation coefficient, and then attenuation similar to water will suggest that we're dealing with a transudate fluid, and attenuation that is greater than water will suggest malignancy, bloody content, or purulent content. And attenuation less than water will suggest chylous fluid. Okay, so based on CT scanning, malignant effusion are associated with thicker pericardium than benign effusions, and the pericardial thickness is greater than 4.1 millimeter, combined with mediastinal lymphadenopathy, provided a high level of differentiation. And finally, sign CT and MRI provide the same CT and MRI provide information similar to echocardiography for assessment of tamponade. Okay, so this is just echo picture. There's personal long axis view here. There's almost like a circumferential effusion here. And looking at this middle picture, there is an indentation collapse of on the right ventricle. Looking at this particular picture here. Okay, still here you also have like an indentation collapse of the right atrium here with effusion all around. Okay, so this is just let's see, just the video. It's not playing. Okay. So here you can notice there's collapse of the right atrium, and also even collapse of the left here. There's also some little partial collapse of the right ventricle there. Okay. Okay, so management. Management is detected first and foremost by whether the tamponade is present or has a high chance of developing in the near term. And in the absence of actual or threatening tamponade, management can be more done visually. In many cases of effusion, in which tamponade is neither present nor threatening, a cause to be evident and suggested from the history, e.g. neoplastic disease, maybe radiation treatment, and not previously obtained diagnostic test. So in patients without actual or imminent tamponade, pericardiocentesis, closed or open with biopsy, may be undertaken for diagnostic purposes, but is not usually required. So patients with actual or threatening tamponade should be considered a medical emergency, with the exception of patients who do not wish prolongation of life, maybe people with stage 4 metastatic cancer, and so hospital admission and a careful hemodynamic and echocardiography monitoring are mandated. And most patients require pericardiocentesis to treat or prevent the tamponade, and treatment should be individualized, and then thoughtful clinical judgment is also said to be important. For patients with an apparent idiopathic pericarditis who have no more than mild tamponade, they can be treated with a brief period with NSAID and colchicine, and hoping that the effusion will shrink rapidly. But for patients with connective tissue disease and other inflammatory diseases, can be treated in the same way or with a course of steroid, though there's no evidence that corticosteroid increases recurrence in this patient. Hemodynamic monitoring with central venous or pulmonary artery balloon catheter is often used, especially in those with threatening or mild tamponade, in whom a decision is made to defer pericardiocentesis. So monitoring is also helpful after pericardiocentesis to assess for reaccumulation and the presence of underlying constrictive disease. However, insertion of a catheter in the central circulation should not be allowed to delay definitive therapy in critically ill patients. For most patients in this category, management should be oriented towards urgent and emergency pericardiocentesis. And so I think basically just pericardiocentesis, they're just talking about the next slide, I'm just talking about other medical things that could be done, like intravenous hydration with saline should be instituted, positive inotrope may be used, but they have limited efficacy. Volume expansion and positive inotropes are temporizing measure, and the above measures should not be allowed to substitute or delay pericardial sentences, basically. So since obstructing me, sorry, 1 minute, please. Okay. So for loculated effusion or effusion containing clots or fibrinous materials are also of concern because of the risk and the difficulty associated with the closed pericardiocentesis are increased. So if removal of the fluid is thought to be necessary, an open approach should be considered. But that's for the cardiothoracic surgeon, for safety and to obtain pericardial tissue and create a window, whether to perform closed versus open pericardiocentesis in patients with known or suspected bleeding into the pericardial sac is said to be a difficult decision. Okay, I think for close-up time, let me just move. Okay, so constrictive pericarditis. So constrictive pericarditis is the end stage of the inflammatory process involving the pericardium. In the developed world, the cause is said to be mostly idiopathic, and it can also be from post-surgical procedure or exposure to radiation, particularly radiation injury. And then in developing world, tuberculosis is said to be the common cause. However, the incidence is said to have reduced due to effective drug management for tuberculosis, and constriction can follow an initial insult by as little as several months and occasionally less, but it typically takes years to develop. And the end result is usually fibrosis, often calcification and adhesion of the pureter and the visceral pericardium. So scarring is generally more or less symmetric, and it impedes filling of both the heart chambers. In the setting of patient with constriction, in this subset of patient with constriction, the constriction is transient and all reversible with the use of anti-inflammatory medications. Okay, and this is observed early after cardiac surgery and in other patients who appear to have intense pericardiac inflammation. So for the etiologies, like I said, initially idiopathic, radiation, surgery, infection, autoimmune uremia, and the likes. Okay. So for constrictive pericarditis, just to use this to explain the pathogenesis, the challenge is that we have a stiff pericardium, like the greenish covering that you can see on the outside, like have a stiff pericardium. So the thickening of the pericardium, which keeps the heart in a form of encasement, as it were, like that. Okay. And then so with this, in this encased heart, there's no problem basically with the heart, but the problem we have here is with the pericardium. And then first to have inflow from the inferior vena cava and the superior vena cava, okay, which should actually feed into the right atrium there. Because the atrium cannot distend adequately during diastole to receive blood. Likewise, the right atrium cannot distend adequately. Okay, so with little inflow of blood into the right atrium, we tend to actually have a increased right filling pressure. Okay, there's increased right atrial filling pressure, and with the increased right atrial filling pressure, and during inspiration, you now tend to have increased JVP, basically. Yeah. So the problem is with distension, the heart cannot receive enough blood, as it were, because it cannot distend. That compliance is impaired by a casing that has been placed outside the heart in the name of the rigid pericardium, basically. Okay, and so on like example, now we have a collapse, but here there's no collapse. But the problem is just that the heart cannot distend enough to receive more blood. So during inspiration, instead of having a drop in the pressure in the right atrium, you now have an increase. So the JVP would be increased. So still going back to the venous, the tracing. The A is for atrial contraction. Okay, the C is for the closure of the tricuspid. The V is for venous filling. On top, as it were, of a closed tricuspid. So in constrictive pericarditis, we tend to actually have prominent X descent and prominent Y descent. Okay, the X descent is due to relaxation of the atrium. Okay, and the Y descent is due to opening of the tricuspid valve. Unlike what we had with the tamponade, there's a collapse. So the tricuspid cannot even open its content into the right ventricle, as it were. Okay, but in constrictive pericarditis, there's no impairment with flow of blood in the heart. The only major problem we tend to have is distension. It can't distend enough to receive. Okay, so there's basically no problem with blood moving through the heart, as it were. So there's prominent X descent, which is due to atrial relaxation, and the blood can also flow because the tricuspid valve can easily open. So you have your Y, descent basically here. Okay. Then also with Kussmaul's sign is when you have increased JVP with respiration, which is much more prominent in constrictive pericarditis, though it may be found in us what's it called again? The tamponade, but it's much more prominent in the constrictive pericarditis. And when you have a prominent Y descent, is another sign. It's also referred to as the Frederick sign. When you have a prominent Y descent, basically. Okay. So just to maybe explain a little more, the pathophysiology. So the pathophysiology consequences of the pericardial scarring is markedly restricted filling of the heart, which I tried to explain. So another important thing is also that there's equilibration of the pressure in the right ventricle and also the pressure in the left ventricle. So due to restricted filling, this results in elevated and equal filling pressure in all chambers and in the systemic and venous veins. So in early diastole, the ventricle fill very rapidly because of marked elevated atrial pressure and accentuated early diastolic ventricular suction, and the later related to the small end diastolic volume. I was trying to explain earlier on. So during early diastole or mid diastole, the ventricular filling abruptly ceases when cardiac volume reaches the limit set by the stiff pericardium. So we can just explain this a little. So usually when you have the rapid ventricular filling, so the ventricles are filling, but there will be an abrupt cessation of that filling. So the abrupt cessation of the filling coincides with when the ventricle kind of eats the rigid pericardium, and it gives a knocking sign, a diastolic knock, which is peculiar with constrictive pericarditis. So when it's rapidly filling, and then all of a sudden, instead of distending as it were to receive more blood, the ventricle kind of eats the stiff pericardium or rigid pericardium. So that contact it makes with the pericardium gives a noise which is referred to as diastolic knock, which is a classical with a constrictive pericarditis. Okay, so systemic venous congestion results in hepatic congestion because the heart can't receive enough because it can't they can't distend to receive more. So there will be venous congestion. So there will be hepatic congestion, peripheral edema, there will be ascites and asaka, and we also have cardiac cirrhosis. And so invariably, if you cannot receive so much, that means you cannot give out so much. So there's reduced cardiac output as a consequence of impaired filling. And then because the basic metabolic requirement of the body will not be met, there will be fatigue. Over time, a patient will have muscle wasting and weight loss. So in pure constriction, contractile function is preserved. Like I said, there's no issue with the heart muscle as it were, although the ejection fraction can be reduced as a result of reduced preload. Okay, so the myocardium is occasionally involved in inflammation and fibrosis, which may lead to contractile dysfunction that can be quite severe and predict a poor response. So, but they said occasionally, sometimes the inflammation may also now affect the myocardium, but doesn't really always affect the myocardium. But there are instances where that inflammation going on outside can also affect the myocardium and could affect the contractile function of the myocardium. Okay. So for the clinical features, you tend to actually find features that are consistent with right-sided heart failure. And at any stage, such as at an early stage, such findings include what we talked about, pida edema, vague abdominal complaint, passive hepatic congestion. So as it worsens, you have ascites and asaka, and they have jaundice, which is secondary to cardiac cirrhosis. So over time, patients will also have symptoms of left heart failure, dyspnea, autopnea, PND. So in the chronic state, the patient are actually said to also notice to develop atrial fibrillation. There could also be tricuspid regurgitation, which further exacerbates the elevation of the venous pressure, and it's said to be common at this stage. Some patients may also even go on to have recurrent pleural effusion and then syncopal attack. So I think I'll try to explain the X and the Y descent with the picture we had earlier on. And then, so it's said that for patients on top of having constrictive pericarditis, when they have atrial fibrillation, then the X descent is usually lost. You won't see the X descent because we said X has to do with relaxation of the atrium. So when you have atrial fibrillation, it automatically knocks off this. So the only thing you might be left with is just a prominent Y, particularly in a patient who has constrictive pericarditis plus atrial fibrillation. Okay, so the Kussmaul sign and respiratory increase in venous pressure is usually present, or the pressure simply fails to decrease on inspiration. Okay, so the Kussmaul sign reflects loss of the normal increase in venous return to the right side of the heart on inspiration, even though tricuspid flow increases. Okay, let me try and speed up because of time. So I think I'll try to explain the pericardial knock. So the pericardial knock is usually felt at the left sternal border due to sudden halting of the ventricle during diastolic filling. And this is best heard at the left sternal border or apex. The apex may also not be palpable in this instance when the patient has a constricted pericarditis, and the heart sound that usually soft, and then an early third heart sound can coincide with when you have the diastolic knock. So in the pulmonary area, there's a sudden instantaneous widening splitting sound which occurs following the first heart sound. This is referred to as a Vogelpuel sign. I guess it's a German word, not too sure of the origin of the word. Okay. So I think we've talked about all of this, the backflow effect, everything just keeps, we've talked about it. So the investigation, the ECG is said to be non-specific with T waves of normality. There will be reduced voltage and left atrial abnormality can be seen. And atrial fibrillation is common in the chronic form. When we do chest X-ray, the cardiac silhouette may be enlarged because of a coexisting pericardial effusion. Pericardial calcification is seen in the minority of patients and then suggests tuberculosis, but is not by itself diagnostic of constrictive physiology. Pleural effusion are common and can be an initial sign, and the left-sided heart filling pressure are markedly elevated. To go up all the signs of ABCD of heart failure over time too. Okay, this is just a chest radiograph which is showing a pericardial calcification. Okay, so for the echo, the findings in echo, we tend to have this pericardial thickening, the thickening of the pericardium. There's a septal bounce. Okay, so what causes septal bounce? So because when blood comes into the right atrium and the right ventricle, it can't distend outwardly. So if it's trying to distend outwardly, the stiff pericardium gives a restriction. Okay, so the only side it could go to is the left side. So there's a pull of blood towards that interventricular septum, thereby pushing on the interventricular septum and reducing the size, relatively the size of the left ventricle. So you have an abrupt displacement of the interventricular septum during early diastole, which is referred to as the septal bounce. Then the signs of systemic venous congestion, because there will backflow to the hepatic vein, distension of the IVC. Then you also tend to have a blunted respiratory fluctuation, which I'll try and explain, I think, in the next slide, and exaggerated septal shifting during inspiration is also present. Okay, so basically, okay, maybe you can just stick to, okay, let's stick to one. So during inspiration, there's this transmitral variation for patients who have constrictive pericarditis. Okay, so in a cycle, you would notice that the height of the EA ratio, though they tend to have a restrictive pattern 1, so the height seems reduced, okay, and the next cycle you're seeing is a bit increased. So it's an alternation between this and this, okay. So you see this, okay, and the next thing you see will be the shorter form. The next one will be the taller form. The next one will be the shorter form. So they tend to have this transmitral variation. Then also, I was trying to check it out before I presented this. I think I once saw it somewhere that when you do your tissue Doppler, basically, the tissue Doppler value at around this point for the septa, it's usually around that, like 7 or thereabout, more than 7. Then on the lateral is around 10. So there tend to be a reversal. I think maybe when we're done, maybe some people can just help me corroborate that. There tends to be a reversal. You now find the tissue Doppler values on the septa longer, and on the lateral part shorter, okay, which is also another sign that could suggest that the patient has constrictive pericarditis, apart from the thickening of the pericardium, the septal bounce, the transmittal variation, which they tend to have, okay? So cardiac characterization and the angiography is also important, and the cardiac characterization in patients with suspected constriction provides documentation of hemodynamics, and then so coronary angiography should ordinarily be performed in patient being considered for pericardectomy, okay? Rarely external pinching or compression of the coronary artery by the constricting pericardium is detected, okay? So basically for constrictive pericarditis, it is said that they have a square sign, okay, which is shown in this picture where I'll try to explain. So this is the ventricle. We're looking at the ventricle here now. The blue is the right ventricle. The left is is it red now, orange? I'm not sure of the color. Is the left ventricle. So looking at the blue, there's a ventricular filling. Okay, so just during this diastole, there's a filling here. Okay, so it's supposed to go much lower as it were, a little more, but because of the inability of the ventricle to distend with the inflow of blood into it, there's an abrupt stoppage at this point. So with the abrupt stoppage, the pressure in the right ventricle gradually rises, and at point it plateaus, okay, which gives the square root sign, which is usually found in patients with constrictive pericarditis, or is usually called deep and plateau. Is another name that is given to it. So this is the square root sign, basically. So I think I'll try to explain the X and Y descent so I can save some time. Okay. So the CT and the MRI is also important, basically looking out for pericardial thickening. For management, so constrictive pericarditis has a progressive but variable cost, and for most patients, surgical pericardectomy is definitive treatment. And patients with major comorbidity conditions and all severe debilitating may be at may be too high a risk for pericardectomy. So radiation-induced disease is considered to be a relative indication to go ahead with the procedure. And then healthy older patient with very mild constriction may be managed non-surgically, but pericardectomy being held in reserve until the disease progresses. Okay, so I think surgery is just the major form of treatment. For the only medical intervention is diuretic and salt restriction are useful, which should help us to reduce the volume overload for patients with, but patients will ultimately have a refractory to this form of treatment. And then this group of patients we noticed to also have sinus tachycardia, which is a form of compensatory mechanism. So beta blocker and calcium antagonists that slow the heart rate should be avoided in them. Okay. And for patients who have atrial fibrillation with rapid ventricular response, DIG can also be given to this group of patients before resorting to give them beta blockers or calcium antagonists. And then while you're trying to control the heart rate, it's advisable that it should stay within the range of 80 to 90. So the last part now, we have the effusive constrictive pericarditis. So patient with the pericardial disease may have a syndrome that combines element of effusion, tamponade, and constriction, which is termed the effusive constrictive pericarditis. And many cases of a transient and or medically treatable constrictive pericarditis probably present a late stage of an effusive constrictive pericarditis. And the cause may be quite variable, but in most, it is subacute and ranges from perhaps a month to a year. So the inflammatory effusion typically dominates early. That means there's production of fluid, as it were, with constriction being prominent later. So the visceral pericardium is usually prominently involved, and these patients are often identified when their hemodynamics fail to normalize after pericardiocentesis. So they do pericardiocentesis for patients, and the hemodynamic situation still fails to resolve. So commonly accepted definition is failure of right atrial pressure to decline by at least 50% to a level below 10 millimeters of mercury when pericardial pressure is reduced to almost zero, or by pericardiocentesis, and all detectable fluid are removed. Okay, so the reported incidence of effusive constrictive pericarditis in patients with pericardial effusion is approximately 4 to 5%, but it can vary from 1 to 15% also. So effusive constrictive pericarditis may be missed if hemodynamics is not measured carefully after pericardiocentesis. And then the causes are diverse, with more common being idiopathic malignancy, radiation, tuberculosis, pericardectomy, and connective tissue disease. And TB is said to be the leading cause in sub-Saharan Africa. And the physical hemodynamic and echo findings are often mixture of this associated with effusion and constriction. and may vary with time as the syndrome progresses. So for diagnosis, it may require the acquisition of pericardial fluid and also biopsy specimen if the cause is not obvious and tamponade does not mandate pericardiocentesis, okay? And it is important to be cautious when performing close pericardiocentesis in patients without large effusion. So management is tailored to the specific cause if it is known. In idiopathic cases, anti-inflammatory treatment must be used in an attempt to avoid pericardectomy, but no guidance is available in regard to the preferred approach. And then in idiopathic and post-pericardectomy cases with a tamponade and a physiconstructive physiology documented at the time of pericardiocentesis, a course of steroid and colchicine as outlined for medical treatment of reconstruction, and pericardectomy is ultimately required in many of these patients. So in closing, just to look at differences between tamponade and constrictive pericarditis, and I'll occasionally talk about restrictive, and the last one is the right ventricular myocardial infarction, but we'll focus more on tamponade and constrictive pericarditis. So for Postle's paradoxus, it is common in tamponade, but it's said to be found in about a third of patients with constrictive pericarditis, and it's very rare in restrictive. Like we talked about the jugular veins. For tamponade, we said they have a prominent X, and then Y is absent, and why Y is absent is due to the collapse of the right ventricle. So the atrium can't even empty what it has because there's a collapse of the right ventricle, okay? However, in constrictive, there's no problem with flow in between. What has a problem is the casing, the encasement that has imprisoned the heart, as it were. So the X will be present, the Y will be present in them, okay? And then the Kussmaul sign, though may be present in a few people, but usually prominently present in constrictive pericarditis, and is also present in a restrictive cardiomyopathy. So third heart sign said to be absent across board and rare in may be found in the restrictive cardiomyopathy. Pericardiac knock is exclusive for constrictive pericarditis, which I tried to explain earlier on. Looking at the ECG, all of them have a low voltage complex across board, okay? And electrical alternance is usually found with tamponade, okay, which has to do with the movement of the heart in a large pool of fluid back and forth, basically. So for the echocardiography, they constricted the thickening pericardium. So for tamponade, there's no problem with thickening of the pericardium. The major challenge we have is that there's so much fluid surrounding the heart, we tend to compress. So no issue with the pericardium. And the pericardial calcification is often present in constrictive, which is not found in tamponade. Then pericardial effusion is usually present and usually mild to moderate, moderate to severe in tamponade. Maybe absent or maybe just a little, usually absent in constrictive pericarditis, okay? Then the myocardial thickness is normal in tamponade, constrictive, but maybe usually be increased in the infiltrative disease where we have restrictive cardiomyopathy, basically. Okay, let me just go to. Then there's, like I said earlier on, there's equalization, which is usually more present in a constrictive pericarditis as compared to tamponade. Okay, so the equalization is due to that rigid casing in constrictive pericarditis. But what can give that picture in tamponade will be the fluid surrounding the heart, basically. And I think also the square root sign is peculiar for constrictive pericarditis, though it is said that it may also be seen in restrictive cardiomyopathy, but usually very small, if even at all you see any. Thank you for listening.
Wow. Wow. Dr. Austin, this is
Yes,
impressive.
Yes,
this, I'm calling your name again. This is the permit me to say this, but since I started cardiology training, this is one of the best presentation on pericardial diseases. If Professor Keala, if any examiner gets a hold of this your slide, the kind of MCQ they will generate, it will be difficult to attempt. Wow. And you know, class, the interesting thing about Austin is I gave him this topic very late. I'm so impressed. Like, it was a very short time. I just called, he said he wants to join the group. I said, okay, all right. As a proof that you want to join the group, we are going to do a presentation on pericardial disease, and he accepted. And we added him on Monday also. Today is presenting a wow presentation. Well, for me, very, very, I'm just surprised. And he's on call today. Please, he's on call. The floor is open for us to make contributions so that he can join up with the patient waiting for him. Austin, thank you so much.
Welcome,
That's all
sir.
I can say. Thank you. You answer so many past questions. You answer Brownwell. You answer Prof's questions. I thought, wow, well done, well done, well done. I'm impressed. Please, the floor is open, please. Dr. Fatima.
Yeah. This is really a wow presentation.
Wow.
Sorry, please criticize so that I can learn some more, please.
Okay, well done, Dr.
Austin.
Augustine. No, we are really happy with this presentation. He did excellent. My contribution, starting from the anatomy, the pericardial layer consists of 3 layers. First is the fibrous pericardium, followed by the serous pericardium. And the serous pericardium consists of the parietal and the visceral pericardium. It is in between the visceral and parietal pericardium, as you rightly said, that the pericardial fluid is, which is about 15 to 50 mils. And this pericardial fluid is a plasma ultrafiltration fluid with low concentration of sodium, chloride, calcium, magnesium, as well as low plasma protein, but a higher concentration of potassium. So that is one. Then about the pericardial physiology, I think it's important to mention that apart from protection from infection, the pericardium also serves to preserve the negative endothoracic pressure, which is crucial for atrial filling. It also provides nervous stimulation response and regulation of cardiac frequency and arterial blood pressure. It also provides formation of hydrostatic compensation system, thereby ensuring that end-diastolic pressure remains the same at all hydrostatic levels and the Frank-Starling mechanism remains functional. So that is about the anatomy and physiology. Then the issue of treatment of acute pericarditis. I don't know if I got you right or wrong. You were saying aspirin and NSAID. So I thought the treatment should be either with aspirin or ibuprofen, other types of NSAIDs, not given both at a time in combination with the
is one of them, please. One of them. NSAID, just pick one.
Okay, so maybe it's slip of tongue. All right, so that's good. Then regarding the transthoracic echo, which one is most specific and which one is most sensitive between RV collapse and RA collapse for cardiac tamponade? Then what is the most specific finding? Is it RV collapse? Which one is most specific for tamponade? RV or RA collapse?
I think RV collapse.
Yeah, RV collapse is the most specific. Then what is the management of recurrent pericardial effusion? Then, regarding the tissue Doppler finding in constrictive pericarditis, I think they usually have annulus reversus with the septal E prime greater than 8 centimeter per second. Yeah. So thank you.
Dr. Austin, that was what you were trying to explain.
Yes,
the
that
analysis
I
versus
couldn't find it in any text, but one of my consultants
in
made that
Brownwald.
contribution. Okay.
It's in Brownwald. We answered it as one of our questions before you joined the group. That was why I was trying to say that I'm just wowed. Like, we went through Brownwald and your presentation showed that you spent time, and it was a short duration I gave you. I wonder how you did. Well done. Well
Thanks,
done
sir.
again. I'll give you a personal call to say thank you.
Thank you, sir.
Well done. Please, the floor is further open for further contribution. Dr. Conte, please.
Yes. Thank you very much, Augustine, for that very detailed and extensive presentation. Just a few comments regarding the ECG findings in acute pericarditis. There is also another sign that you can see in stage 1. It's called spondic sign.
Spondic sign, yes.
Spondic, yeah. Spondic sign. S-P-O-D-I-C. Spondic sign. So it occurs in stage 1. It is not very sensitive, seen only about 30%, but it's highly specific. So the spondic sign is a downsloping
on the T
segment. So the segment between the preceding P wave and the following P wave, that segment, if you see downsloping, okay, that is a spondic sign. So that is, those are things that might come in MCQs. And then
okay,
the other
I get
thing,
you. Sorry, yeah. Dr. Conte. Sorry, please, just to get you correctly, because I don't know, my network was not clear at some point. Can you please help us type this spondic sign when you are done on the chat? And what?
Can I please?
If you can just help us type it on the chat, because I didn't get it clearly.
Okay, yeah,
you said
it, definitely.
Yes. Yeah. All right.
Yeah. The other thing about this X and Y descent in tamponade and constrictive pericarditis. I think you've done a good job explaining it. It's just that there is a little bit of oversimplification. You go back to those diagrams, let me just talk about it, just a little bit. So when you actually look at the part of the hemodynamics, it is correct that you see a prominent X descent in tamponade and a prominent Y descent in constrictive. So in constrictive, the X descent is actually dampened. I'll explain that. First of all, let's just recap a little bit the causes of the descent. Okay, so the Y descent, of course, is okay. That is rapid passive ventricular filling is what produced the Y descent. Now the X descent is actually produced by 2 processes, not one, like what you see in the Y descent. So the first part of the X descent from the A wave, the peak of the A wave, down to the C wave is actually produced by atrial relaxation. Okay, so from the A wave down to the C wave is produced by atrial relaxation. And the rest of the X descent after closure of the tricuspid valve is actually produced by pulling of the AV annulus towards the apex of the heart during systole. I go over that again. The second part of the X descent is produced by pulling of the AV annulus towards the apex during ventricular systole. That is what produced the rest of the X descent. Now, that said, diastolic filling, can be considered into 3 halves. Okay? The first half, the middle half, and then the first third, the middle third, and the last third. Okay? In normal life, the first 2 thirds, they are passive filling. All right? And then the last 1/3 is due to atrial contraction. Okay? So as you rightly mentioned, when you have constrictive pericarditis, most of the feeling that is going to happen in the heart is happening during the first half of diastole. Maybe a little bit will go into the second half, but most of it is happening in the first half, because as soon as the heart begins to expand, it is then restricted by this case. So all the feeling that is going to happen should happen in that first third of diastole. After that, even if the atria try to contract, there is no space to accommodate because the heart is in a case. It can't go further. Okay, and that is why your Y descent is very prominent, because all the feeling that is happening in the whole of the heart is happening within that short period. And that's why the Y descent almost becomes vertical. It is happening within a very short time. And when you come to the X descent, it would not be prominent in constrictive pericarditis. It actually will be blunted because atrial contraction will occur, but it is not producing pressure changes because the atrial pressure is already high in tamponade. When they say equalization of the pressure, it's already high. Okay, and so no feeling is not produced by that contraction because the ventricle has no way to expand further to accommodate any more feeling. It is in that fixed state. The feeling is restricted to that one thought. So the Y will be prominent and the X is blunted. And if you go to the pictures that you show of the catheterization hemodynamics, it is very clear in that when they show the atria, that the Y is there prominently, but the X is blunted. So both of them are not prominent in ES. See, the X is blunted and the Y is prominent. Okay. And then if we go back, the reverse now happened in tamponade. So in tamponade, again, you consider the diastolic feeling, those three phases. Because the right ventricle is collapsed because of that pressure around. You are not, those first 2/3 of feeling that are passive, very minimal will occur because the right ventricle is collapsed. Those first 2/3 of your passive feeling, very minimal would occur. All right. So all your feeling, you depend in tamponade, you depend on the atrial contraction. You depend on the atrial contraction for your feeling. So your feeling is happening in the last third of diastole. The first 2/3, because the right ventricle is collapsed, you are not getting any passive feeling at all. Okay. So that picture, that's why it is a bit oversimplified, because most of your feeling is dependent on the A wave will be bigger. Okay, the A wave will be bigger because that is what is responsible for moving most of the blood in tamponade. Okay, and then the X descent will continue. So the portion of the A wave contributing to the X descent should actually be more, and then the remaining portion, okay, will still be there, will be prominent as well, because in addition to the pulling of the AV annulus towards the apex when the heart contracts, in tamponade, when the ventricles contract also, they eject their blood out. Okay, they eject their blood out. So that reduces the volume of the ventricle. All right, because they are ejecting their content. So it reduces the volume of the ventricle. And you know, in tamponade, there is fluid inside the pericardium. Okay, so when you reduce the volume of the ventricle, it reduces the pressure within the pericardium because some of the volume is being shed. And that reduction in the volume within the pericardium further causes this prominent of this Y descent. Okay, so the prominent, sorry, not Y, X descent. So the prominent X descent in tamponade, three things contribute to it. So the atrial relaxation, because most of the feeling is occurring by atrial contraction, and then the contraction of the ventricles themselves, pulling the AV annulus towards the apex. And also when the ventricles empty their contents, it reduces the amount of volume within the pericardium, and it causes a relief over. So like the fluid moves to fill that space that is created around the ventricle and cause some relief around the atrium. So it further drops the atrial pressure. And that's why, so it's the X descent that will be prominent. Of course, the Y is blunted because the ventricular collapse, so passive filling is not, very minimal passive filling is occurring, so it will be blunted. Yeah, I think that's just the thing I needed to highlight. Then the last thing is in terms of practical aspect with tamponade. You correctly mentioned fluid administration in tamponade is very important, because when a person comes in tamponade, it's like when you are in the emergency, you will not have everything ready for you to do pericardiocentesis immediately. You need time to get the things set up and then go ahead with the procedure. So in that period, your bolus fluid is very important to give IV bolus of fluid. Because when you give that IV bolus venous fluid, okay, 500 mils, very fast, it expands the intracardiac volume, and you're sort of that, and that will sort of help a bit to counter the pressure that is in the pericardium and encourage a bit more filling of the heart in the short term as you now prepare for your pericardiocentesis, which will be the definitive thing to do. Another important thing that they will tend to ask about this pericardiocentesis in tamponade, they will ask you how much fluid would you remove to relieve the tamponade, okay? And the answer to that, there is no measurement of how much fluid you need to remove. You just need to remove enough to reverse the hemodynamic, to make sure that the pericardial pressure drops below the intracardiac pressure, and then you'll allow filling. Okay, so there is no particular measurement. You just need to observe the patient, and as you drain, especially if you happen to get the patient in the periphery where everything is not available to do a complete drainage. You can even use a cannula, like the green cannula, okay? And then just aspirate. You aspirate as you monitor the patient. You can aspirate up to 50 mils, okay? And then that can relieve the pressure, and you can sustain the patient and then transfer the patient to a tertiary center where they can do a proper drain and actually be able to drain all the fluid from the pericardium. So those are just a few comments I had to make. Thank you.
Thank you very much.
Thank you so much, Dr. Conte. Thank you for that excellent contribution. Please help us out again with the spondic sign. She can type it to us in the chat box.
I'll try and put it in the slide before I put it on the page. I think I have a slide on it. I wasn't able to get a full explanation of it. That's why I took it off. So I'll put it back.
Oh, excellent. Excellent. Please, thank you so much, Dr. Austin, again. The floor is open for more comments. Please, Dr. Austin is on call. Let's be fast about it. Dr. Siri, over to you.
Thank you, Chief Okopi. Dr. Austin, thank you very much for the presentation.
Welcome, sir.
Just a quick one. How remarkable ECG in a recurrent or chronic pericarditis rule out pericarditis in the diagnosis?
You mean the ECG, right?
Yes.
Okay, from what I actually read, they talked more about, for recurrent, patient would have been free for 4 to 6 weeks before the patient actually comes down with acute pericarditis again. So what is actually noted to use to monitor is the CRP. I think I have, let me just go back there. I think this CRP, if I'm mistaken, I think it's the CRP used to actually monitor. And that may also determine to what extent you want to treat the patient to actually make sure the pericarditis doesn't recur again. I think, yeah. Okay. So I think there wasn't so much emphasis on the ECG, because the ECG would have been the changes would have reversed back to like normal, and patient will be fine for 4 to 6 weeks before patient now comes down again with another episode, and that may also be very important to know that patients who have all this connective tissue disease are susceptible to having recurrent form of pericarditis. So, and the duration of treatment may be longer, like the colchicine could give as long as more than six months. And then if you are still not getting response, some people suggest you could actually maybe add steroid if everything you've tried hasn't worked.
Thank you very much. I think that is the fact that it can actually reverse and you can get a remarkable ECG while the cause of the inflammation is still on. Thank you.
So just to add, after the steroid, I think you can use azathioprine also, intravenous immunoglobulins, if you're still not getting the required outcome.
Thank you so much. Thank you so much. Dr. Jacqueline.
Thank you very much, Dr. Odayi, for your presentation. It was very lucid and clear. I just wanted to ask a question. Did you come across any term like non-specific pericarditis when you were preparing?
I'm not sure. No, I think the question I even wanted to ask was, I think they were using recurrent with relapsing pericarditis. So I was trying to sort that out, but I didn't find that particular one you talked about. But from the classification I have here, the bulk of what I saw were this. Let me just quickly take you to that point. Okay. Incessant pericarditis, recurrent, chronic. Those were the few ones I saw while I was working on this.
Okay, I brought it up because it came out in a past question, one of the past subspecialty questions, I think 2021. So I'm just wondering because I've tried to look for it. I've not seen any specific place where it was actually discussed. So that's what I'm asking. But thank you very much.
What is it? What is it again you mentioned, Dr. Jacqueline?
Non-specific, as in the question is actually to discuss about non-specific pericarditis.
Okay, I think that question I asked, it was almost related to can we discuss that as idiopathic?
Okay, no problem.
Because I think when they asked me that question, I asked Prof.
Okay.
After them, Professor Ladimir this exam. So when I saw the past question, I took it up. So I asked Prof.
Okay.
Wow. Please, I wish we can give this man a round of applause, but it's not possible because we can clap our hands now. But Dr. Austin, thank you. This is quite impressive. Particularly impressive that you could do this within a short time and also under the pressure of the fact that you're on call. Thank you for the sacrifice. It is beyond the obligation that you have. It is beyond the obligation that you have to present. This is quite impressive. Thank you. You're a good man.
Yes,
so please, we'll allow you to go for your call.
Thank you.
And have a calm call, please.
Amen. Oh, very important one. Let me unshare now.
Yes, please fill up those stuff and give us the slides so that those going for exam
I want to make the addition. Maybe when I'm done in the end, you had a few things there. Maybe by 12 or thereabout, I'll drop it on the central page.
All right, thank you so much.
Okay, please, thank you very much. We need that slide.
Okay, ma'am.
Thank you for announcing yourself in a big way. Thank you.
Wow.
Well done. All right, so we'll go to the discussions now. The past questions of Prof. I'll share. I can't remember the question. I can't remember the question we stopped. Okay, Dr. Goodyear, please.
That should be question 18.
Are you sure we can take your pacemaker presentation today? Hello?
Or copy.
Dr. Goodyear. Yes, sir.
Okay.
Hello, sir. I think you have two devices. Do you want to still take your pacemaker? Can you still take the pacemaker presentation today?
Okay, if there won't be time, we'll present it some other time.
No, there's still time. We are finishing today by 11. If we can dedicate today for presentation, then tomorrow we can go back to prof because we are also preparing for orals. Like what Augustine just did now, we have to palm these pericardial diseases, and then that's all for anything oral from pericardial diseases. And I know pacemaker is something that we will need to know again. So I don't know, the house, should we answer the first MCQ or we should just take the pacemaker presentation today? Because we have a lot of presentation handy and the people are ready.
And we can do the pacemaker today.
All right, sir. Okay, thank you so much. So Dr. Goodia, please share your slide.
Okay, I think, have I started sharing?
Yes, you started.
Okay, thank you very much. I will be taking us through pacemakers and pacemaker malfunctions. I'll try to follow this outline. Well, effective pumping mechanism of the heart actually require that the atria and the ventricle to be activated rapidly and sequentially. By rapid activations, I mean that many myocardial cells should be activated simultaneously as much as possible. And sequential means that the atria should activate first and fill the ventricle with adequate blood before the ventricle contracts. So these acts are usually coordinated by an intrinsic pacemaker and conducting system, which are found in the heart. So the conducting cells actually form bundles of fibers that spread in the or they spread the action potential rapidly and sequentially to the contracting myocardium. The myocardium will receive the action potential and transmit it to neighboring cells and also use it to activate itself and contract. So as we all know that the impulse usually is generated from group of cells within the conducting system that are termed the pacemaker. And usually in a normal heart, we have a lot of pacemakers scattered, but the ones that are within the sinoatrial node actually have a rapid depolarization rate spontaneously that reaches about 70 to 80 depolarization per minute. So because of this rapid depolarization of theirs, they usually override the other pacemakers within the heart, and they take the lead and distribute their impulse or their action potential to, or rather their impulse to other cells, and that will lead to their depolarization. So aside from the sinoatrial node, which is known as the primary pacemaker, we have other secondary pacemakers, which are known as the latent pacemakers. They are found scattered all over the heart. Usually on the atrium, we have them around the point of entry of the inferior vena cava, the crista terminalis, and then around the leaflets of the mitral and tricuspid valve leaflets. So, and also around the point of entry of the sinus veins. So all these cells can actually on their own start depolarizing spontaneously, but they have a slower rate compared to the SA node. So there are other cells also around the atrioventricular node which are also termed secondary pacemaker cells. And then we have them scattered around the Purkinje fiber. So usually when this primary pacemaker fail to depolarize, one of these latent cells or the secondary pacemakers will pick up and start firing at a rate commensurate with firing ability. And that will lead to spontaneous depolarization of other cells within the heart. So even though these cells can perform the function of the pacemakers, but they're usually not trusted because their action potential usually, if they start firing, actually that if these cells other than the sinoatrial node are the ones who are firing, they are usually called the escape regime. So there are two fundamental shortcomings of this escape regime. One is that the frequency of the depolarization is lower than that of sinoatrial node, which I mentioned, and that means that there will be bradycardia, and with bradycardia, we will have reduced cardiac output. And also, the escape regimes are unreliable in the sense that they have long-time problem. Their activity may decide to completely cease, which may result in asystole. So because of this, they are usually problematic when they are the one driving the heart. And as such, because of the problems, we need an artificial pacemaker, which will replace their function. And this artificial pacemaker is designed in such a way that it works in similitude to what the SA node actually does to the heart. So this device is an implantable medical device that generates electrical impulse and delivered by electrode to the chambers of the heart, either the upper atria or lower ventricle, to cause the targeted cell chambers to contract and pump blood. By doing so, the artificial pacemakers, just as I said, will take over the function of the primary SA node as the pacemaker to regulate the function of the heart electrical conduction, to regulate the function of the generation of the impulse and also transmission of the that electrical impulse to the heart. So there are different types of artificial pacemakers, and I would like to classify them based on duration as permanent and temporary, and based on route of insertion of their leads, and where they stimulate as transvenous, transcutaneous, or epicardial. Sorry, the second one is supposed to be transcutaneous, actually. It's typographical error. Then they can also be classified based on number of chambers that they pace. A single chamber, that is when we use it to pace either the atrium or we use it to pace only the ventricle. And it can be classified as dual chamber if the right atrium and the right ventricle are paced using the same pacemaker. Pacemaker can also be biventricular pacemaker. That is when the right atrium, the right ventricle, and the left ventricle are paced at the same time using the same pacemaker. And this is obtainable in cardiac resynchronization. So these are the types of the example of the pacemakers. So to the left of your screen, you will see a different temporary pacemaker device. The first one that has two connectors on top is a single chamber temporary pacemaker, while the second one that has about 4 connector on top is the dual chamber artificial pacemaker. And these are the materials needed. The one on the right is a pacemaker with the connector and also the materials needed for its insertion. So the permanent pacemakers, I have there's on this screen also, if we look at it, but at our right hand is the permanent pacemaker implantable pulse generator, which is used for permanent pacemaker. And on the left is the transcutaneous spacer. And this transcutaneous spacer is our usual defibrillators that are usually found virtually in all accident and emergency departments. The defibrillator have a knob, which the knob that has that, the half of it is white and the rest of the body look black. You can turn the device, the knob to that pacer and make your connection. You do all the setting and start delivering your pace rhythm. So these are the components of a pacemaker. A pacemaker should comprise of an implantable pulse generator for the permanent pacemaker, or a pacemaker, or a pacer device. So, and in it has the power source, the circuitry, and then the connectors. The connectors means the connecting head. That's for implantable pulse generator, or the pacemaker. You know, those wires and other devices are the connectors. So the leads are, or the leads or wires are has cathodes and anodes on them, except for the unipolar implantable pulse generator, which may have the cathode embedded within the pulse generator. There are some leads of the temporary pacemaker device that are actually not within or around the tip of the wire or the leads, but they can be found somewhere along the length of that lead. So, and they are usually will be within either the vein, the vein, or within the heart, but not in close proximity as is seen in the bipolar lead. So the third component is the body tissue. And these three form the conducting pathway along which the electricity flows. So in them, they have fixators actually on the tip of these wires that help anchor the wires to the cardiac myocyte or the myocardium. And the connectors can be an active when the active connector, that is when it is a screw that is at the, or a passive connector when we have a tine attached to the tip. So this tine is just like a hook. You throw the wire into the heart, and then the tine as the hook will now hook on the myocardium and stabilize the wire there. So just as I mentioned, we have bipolar versus unipolar person. And in bipolar, the cathodes and anodes are usually established or are usually embedded on the tip. And usually they are not that far apart, with a distance of just about 1 centimeter, while in the unipolar, the distance between the cathode and the anode can be as much as 10 centimeter away from the tip and from the tip where the anode is and where the cathode is located. So electron will travel far distance here, and that will mean that more energy will be needed to depolarize the cardiac myocyte. So this is I don't know if I can see a pointer. Good. So this is a screw or an active fixator. So you use this to screw the this lead into the myocardium, while this is a passive one. Beside it are the tines, which are just like those hooks I was mentioning. So this is the implantable pulse generator. So, and also in bipolar, the electrode will move from the anode to the cathode in this direction. So while in the unipolar, the cathode the anode is located somewhere within the pulse generator, and it flows from that pulse generator to the tip where the cathode is. So these are the examples. So these are some examples of epicardial pacemaker electrodes or pacemaker leads, sorry. So the basic pacemaker function, usually the whole essence of pacemaker, just as we said, is to ensure that there is enough energy that is released to the myocardium, which will excite the myocardium and result in depolarization and subsequent conduction of the impulse to the neighboring cells, and which will lead to contraction of the heart. So in order to get a good capture, the pacemaker battery only have certain amount, as we know, of charge, and this charge can be easily drained. So we have to balance the amount of energy that we need to be discharging at each point in time, and as well ensure that the life of the battery is prolonged. So to do this, we have to actually make use of the Ohm's law, which tell us the relationship between the voltage, that's the potential difference, the current, and the resistance. So during pacemaker setting, we can only manipulate the voltage. The current then is affected by both voltage and resistance, which is known as the impedance. That's the total resistance that is found within the wear, the electronic device, and as well the body tissue that the electrodes are in contact with. So we need to have a good understanding of this in order to be able to deliver enough energy that can depolarize our tissue and as well conserve our battery. So we need a threshold energy, which is the minimum electrical energy needed to consistently capture the heart outside the refractory period. And this threshold is affected usually by the amplitude and the pulse width. The amplitude is actually the voltage, and the pulse width is the time or the duration at which the voltage flow to the tissue or myocardial tissue. So it is difficult to tell actually which of them is more important, whether it's the amount of voltage that will be delivered or is the pulse width. So, but however, there's this relationship between voltage duration and then the resistance. If we look at it, if you square the voltage, you increase the energy energy consumption by the rather energy consumption of the battery. So what is normally advocated is that, or rather based on manufacturers may decide to program their system in such a way that both voltage and the time duration will be in such a way that the charge within the battery is not exhausted within a short period of time. So usually that minimum amount of energy that is used to deliver can be determined either by the programmer or by using the by turning knobs on the device until when you are be able to sense depolarization or a pacemaker stimulus is recognized. So, for instance, if you're using the temporary pacemaker, there are knobs on it that once you on the battery, you continue to turn the knob until the light that is indicating person has gone off. Then you turn it back until the light reappeared. Then at that amount of voltage, you will take it at your threshold voltage, at the minimum voltage that can depolarize the myocardium. So that voltage can actually be multiplied by 2 and also the pulse weight by 3 to determine the safety margin, so that if you implant the device in the outside wall, the patient will have fluctuation in either will have fluctuations, and those fluctuations may not affect the sense, the capture when the energy is delivered. So, and to also minimize the battery depletion, most pacemakers usually use lead tips with a very high resistance. Usually the impedance in most pacemakers it ranges from 400 ohms to 120 ohms. Even though there are other books that will say that the impedance should be from 30 to 1,500, and I've seen also a particular book that say from 400 to 1,000 ohms. So it depends on the books you are reading actually, but however, this is what the European guideline on the pacing 2021 actually gave. So once you begin to notice that the impedance on the device is going above 2,000, it's suggesting that there may be lead fracture, and an impedance of less than 200 ohms suggests insulation failure. And this is an example of lead, and this lead actually can be explained. The drainage of current actually when there's lead fracture can be explained by saying that or giving this analogy that normally when you have a water tank, the water in the tank may serve as the charge, and then it is connected to a tap. That tap is like your resistor. So you'll be able to use the tap. When you open the tap, you have reduced the resistance and you allow the potential difference that exists between the tap up and the tank up and the tap to continue to push the water, which is the current, to flow. So when you connect a hose to it and you narrow the tip of the hose, the amount of water that will be flowing will decrease. But at any point that the water, the hose breaks up, you have more water coming out of the hose. And when the whole hose is blocked or break in the sense of a cable, then there may be little or no water flowing. That's the charge flowing. So as a result of that, if we have insulation breakage, more of the current will be wasted. And if we have fracture, then there will be high impedance. So another very important thing that we have to consider when we're talking of pacemaker is the ability to sense. And the sensing is the ability of the pacemaker to see when an intrinsic depolarization occurs within the heart. And it is usually measured in millivolts. And just like I said, you can use the same method that I explained earlier for determining threshold to be able to get a sensing margin that is needed for that particular device. And once that is obtained, you take half of it and program the device with it, because that will be the sensing margin. There may be variation into the when the patient goes into the outside world. So there are other settings that you will need to actually adjust before you place a pacemaker device on a patient who require them. And these settings include things like lower rate limits or the base rate, which is the slowest rate the pacemaker can allow the patient heart to go before it paces. And each heartbeat will show up in one of these two ways, depending on the program mode. That is, when it is sensed before, if there's sensing before the base rate elapse, the pacemaker will inhibit, and then it will reset the base rate again from where that intrinsic heart activity was sensed. But if it did not sense an activity at the end of, or at the end of the timer, the pacemaker will pace at the end of the lower rate limit and stimulate the heart to contract. So there are other times that we need to set, more especially when we are dealing with dual chamber pacing. These are refractory period, which is the period following a pace or a sense beat, in which the pacemaker will see a sense event but will not respond to those events. And among the refractory period, we have the post-ventricular atrial refractory period. And this is a period from the beginning of the ventricular pacing to the end of the T wave, in which the atrium will not sense an event, but even if it senses an event, rather, it will not respond to it. Then we have blanking. In blanking, this is these are programs that, or timers that are set for the pacemaker to disable its sensing amplifier after a pacing pulse is sensed from either the atrium or the ventricle. The purpose of this is actually to prevent crosstalk, because if the ventricular person is also sensed by the atrium, then, or the atrial person is sensed by the ventricle, then there will be pacemaker dysfunction. So in order to prevent this crosstalk, we blank either the atrium or the we blank the ventricle when the atrium is pacing, and blank the atrium when the ventricle is pacing. So there are other timers that can be set. The AV delay, more especially when we are tracking an atrial or a P wave. So we can set the AV delay mode or the VA mode, and the VV, that's the ventricular atrial timer and the ventricular timer, which is the same thing as the base rate. And then the total atrial repolarization period, which is usually the post-ventricular atrial repolarization time plus the AV delay. That will give you the total atrial repolarization time. And there are other settings that may be necessary depending on the type of type of pacemaker and what you are trying to achieve. So there's another setting that is usually utilized, more especially when you are tracking the P waves using a dual chamber mode. And this is known as the upper rate limit. This timer serves as a maximum speed limit that it can allow the pacemaker, or rather, it can allow the pacemaker to respond to the heart intrinsic atrial or other P waves that are coming from either an intrinsic or a paced P wave coming from the atrium. So the maximum speed or the rate at which the pacemaker can pace at should never exceed this upper rate limit. So this limits how fast a P wave is tracked to the ventricle as a safety feature, so that if the patient develops atrial arrhythmia such as atrial fibrillation, the ventricle doesn't pace at the same rate with the atrial arrhythmias. This is how this timers actually work. When we are using the single chamber lead, that is the atrial lead. We put a lead on the atrium to pace the atrium and sense the atrium. When it senses intrinsic activity, it should depolarize. So once we set this, we have to set this timer. That's this atrial repolarization period, which is I said the total atrial repolarization period, which I said it comprises the AV delay, which is from this point to this point, and the pivot, which is from the beginning of this P wave QRS complex to its end here. So this total atrial repolarization period at this point, even if the atrium sense any activity in it, it would not do anything. It will just be watching, and there will be no action that can, or rather, it cannot. At this point, the atrium is completely blinded to whatever signal is coming to it. That's just what it is. So at this lower rate limit is the minimum current, or rather is the minimum heart rate that the pacemaker will allow the intrinsic conduction of the patient heart to go before it paces. So at the expiration of this minimum or this lower rate limit, if the patient the pacemaker in the atrium have not sensed any intrinsic activity, the pacemaker will pace, and then the AV delay will be set. And if there's nothing, or rather, if there's if there is intrinsic ventricle, if this atrial person is transmitted to the ventricle and it causes ventricle and is sensed by the sorry, I'm missing something here. Sorry, it's an atrial pace. So it's only the atrium that is pacing, and this pace rhythm is transmitted to the ventricle and stimulate the ventricle to depolarize. So, and again, the atrium will not sense anything until another cycle starts. So at this point, the atrium senses an intrinsic atrial activity, and it inhibits the pacing. But it does that at a time that the lower rate limit have not actually completed. So it was toward the end of the lower rate limit. So, and because of that, the lower rate limit will be reset to 0 and start running from the beginning again. So at this point that the lower rate limit, it's reset following a sensing of an intrinsic atrial activity is called an escape interval. And the escape interval will continue until the end of the lower rate limit. If it does not sense any atrial activity, it will pace again. And the cycle will continue until it is it will continue like that in the patient's heart. So this is single chamber timing for the ventricle. This VVI is the same thing here. We have the ventricular refractory period. At this point, from the beginning of the QRS complex to the end of the T waves, the ventricle will not sense anything following the pacing of the ventricle, and the ventricle is allowed to pace again, even when it has gone outside this ventricular repolarization period. That is at this point here, from here to here, it can actually pace. But because the lower rate limit time that has been set has not elapsed, it cannot pace. Until when it elapses, then it will pace. And the cycle will continue until when it senses an intrinsic ventricular activity. Then this intrinsic ventricular activity that happens before the end of the lower rate limit will now stimulate an escape rhythm. And this escape rhythm will continue until the end of it. If it does not sense any intrinsic activity, then it will pace again. So the pacing pattern of a dual chamber mode, was particularly the DDD mode, it has four patterns. The atrium can be sensed and the ventricle will be paced, or the atrium will be sensed. Sorry, the atrium is sensed and the ventricle is sensed. That's the first one. Then the second is the atrium is sensed and the ventricle is paced. The third is the atrium is paced and the ventricle is sensed. And the third one, the third pattern that happen in a dual chamber DDD pacemaker is that the atrium can be paced and the ventricle can also be paced at the same time. So this is an example of a ventricle sense and an atrium sense and the ventricle sense at the same time. If we look at it, once the atrium is sensed, the timer for the AV delay will start. And before it ends, that's at the end of this greenish line, if you see that the ventricular activity now starts, an intrinsic ventricular activity start. So it would have waited if ventricular activity had not started. At the end of this AV delay, the pacemaker would have paced. But since it has started before the AV delay elapsed, the timer will be reset to 0 and start counting again. So, and this is the VA interval. That's the time from the ventricular person to another atrial person. So, but because which is this is our lower rate limit. So before this every delay is completed after the ventricular sensing, after the atrial sensing, a ventricular activity, an intrinsic ventricular activity was now sensed. So, and because of that, and being the fact that it was sensed before the lower rate limit elapsed, the pacemaker will reset the lower rate limit to 0 and reset the VV interval to 0, and the timers, they will all continue to run, and the cycle will continue like that with the pacemaker in situ. So this one is for atrial sense ventricular pace. So in this, the atrium is sensed, and then no intrinsic ventricular activity is sensed during the AV delay, and at the end of the AV delay, the ventricular pace, and the timer continued to run for a VA interval and also for lower rate limit. So, and at this point in time of the VA interval, we have an atrial sensing. So because the atrium, the atrial activity, intrinsic atrial activity have been sensed, the timer will be reset, and then the timer for the ventricular delay, AV delay will start. At the end of the AV delay, we have a pace, a ventricular pace reading, because no intrinsic ventricular reading was sensed, and the timer continues like that. That's for the A sense and V pace. So for the A pace and V sense, we have a pacemaker delivered in the ventricle, in the atrium. This is the first pacemaker stimulus, pacemaker spike. This ventricular, atrial depolarization. And from the start of this pacing activity, from the start of this atrial pacing, the AV delay timer starts. It is moving, and at this point, a ventricular an intrinsic ventricular activity is sensed. Possibly the atrium that was paced have been transmitted to the ventricle now. So it was sensed before the end of the AV delay. So the timer will restart. The lower rate limit also start. The timers continue to run at the same time. It got to this point at the end of the VA interval, that's ventriculoatrial interval. The atrium was paced again, and the timer for the AV delay starts, and somewhere here, the ventricle, the ventricle depolarized, and the ventricle sense the lead in the ventricle sense an intrinsic ventricular activity, and the timer for the AV delay start again, and the cycle continue like that So this one is for the dual chamber atrium pace and ventricular pace. The atrium pace, the timer start, the AV delay timer start, no intrinsic activity at the end of the AV delay timer, the ventricle is paced. It continue. The VA interval continue. The lower rate limit also continue to run. So at the end of the VA interval, the atrium is paced again. The timer for the AV delay starts again. So the cycle continue. So these are all the timers actually that can be set at the same time. And but all these timers are very, very important because as we will see, there are timing modes that may result in some abnormalities of the pacemaker that can actually be diagnosed as abnormality, but it's not usually abnormality of the pacemaker per se, but because of the way the timings were programmed. So if the intrinsic heart activity is faster than some of these timers, it can result to or it can result in those abnormalities that we will see subsequently. So these are the total timers. These are the ventricular blanking. At this point that the atrium is paced, all the sensors of the ventricular lead, the amplifier of the sensors will go off. They won't sense anything, so that there won't be communication of this pacing activity with the ventricular activity. It has to go through the atrium. The atrium this atrial activity. So the atrium will have to depolarize. At the end of the atrial depolarization, the AV delay will start. At the end of the AV delay, the ventricle will pace, and then there will be a blanking. When the ventricle is being paced, the atrium will blank. That's all the sensors in the atrium that would have detected or would have sensed this ventricular activity will go off. So the cycle will continue, and the post-ventricular atrial repolarization timer will start. The ventricular atrial interval will also ventricular atrial interval will also start. The upper rate limit will start running, and the lower rate limit will all start running. So this is typical of a dual chamber pacemaker settings. All these settings have to be in place. There's another setting that is, or rather, there is something that is called the upper rate behaviors. With all of these timers that are going on, telling the pacemakers when to pace and when to sense, some timers are likely to overlap and interact with each other. There are instances certain sensing happen during the right time, but some funny pacemakers behaviors occur. These behaviors are known as upper rate behaviors, and these behaviors occurs only when a P wave striking, or rather when we are tracking the P waves at the P wave tracking is happening at an upper rate limit or a maximum tracking rate. So it is important also for us to note that this is not a malfunction of the pacemaker, but rather it is the fact that pacemaker is bound by certain rules, and that it must follow it must follow it, making it appear as if there is something wrong with the pacemaker when it is when it is actuality it is normal pacemaker function. So what are those things? If this happens, actually the trick is to program the pacemaker in such a way to minimize any of these upper rate behaviors. And there are 3 of such upper rate behaviors: the 2-to-1 block, the pacemaker wake back, and the pacemaker mediated tachycardia. So the upper rate behaviors occur when the pacemaker is pivot or is P-wave tracking, and intrinsic beat happens before 1 or more of the timer timeout. So, and usually the timers that are usually implicated in these pacemaker behaviors are the post-ventricular atrial repolarization time, the total atrial repolarization refractory atrial atrial refractory period, sorry, not repolarization time. And this is total atrial refractory period. This is the upper rate limit, which is also known as maximum timing rate. So for waking back, actually the major problem starts when you have the heart rate, this the intrinsic rate is moving at the rate faster than the maximum tracking rate, which is this one. So all these other timers are actually running normally, but this maximum track rate is what is the problem. So now there's an intrinsic atrial depolarization here that happens at the beginning of the atrial depolarization. The AV timer was set on, and the total atrial refractory period timer was also set on. So, but nothing happened. No ventricular activity was sensed up till the end of the AV delay. So the ventricle now paced, and it captured and produced this QRS complex, which actually will not allow for any atrial activity because it's in total atrial refractory period or post-ventricular atrial refractory period. So until at the end of these T waves. So the atrium at this point from here is free to sense any activity. So it now senses an intrinsic atrial activity earlier. So, and since it has sensed an atrial activity, it will set up the AV timer. But the AV timer, that's the AV delay timer elapsed, and the maximum track rate have not elapsed. So, and this is the rate at which you have set your heart, that it can never go beyond this. That's the pacemaker. It can never pace faster than this. So it will wait. It will continue to wait. So it waited for this duration before it now paced at the end of the total, or rather at the end of the maximum track rate. So if you look at it, you will see that the PR interval here is shorter than the PR interval from this point to this point because of this waiting period that it has to do. So if this happens in multiple succession, it will get to a point whereby this P wave will occur at the time that the maximum track rate have not elapsed. That's the timer for the maximum track rate have not elapsed. So the P wave occurred, the maximum track rate have not elapsed. So of course, it is not going to be it's not going to be sensed by the AV timer. And since it's not going to be sensed by the AV timer, there won't be any ventricular pacing. So until at the end of this maximum track rate. So the maximum track rate happened almost in the middle between this the beginning of this T wave here and this one. So nothing happens. It continued to wait, at least from this point to this point, that nothing has happened. Anything could have happened. If atrial activity had happened at this point, it will trigger another timer. So it did not happen until at this point. So when it happened, it triggered this AV delay timer again. At the end of the AV delay timer, we now have the ventricular pacing, and the process continue again. The elongation continue until it drop again. So this is what is known as the Wacom back. This is 4 to 3 Wacom block. That's the Wacom back that is seen in pacemaker. And the problem is actually because of the post-ventricular atrial refractory period, total atrial refractory period, and this maximum track rate that have been said is the ones, they are the timer that are affecting effective communication between the ventricle and the atrium in this particular one. So we have an upper rate behavior also that produce 2-to-1 block. In this one, we say that the period of time following a pace or sense beat in which the pacemaker will see sense event but will not respond to those sense events is what is known as refractory period. So we have this the pacemaker, the intrinsic activity of the atrium is sensed, and it set the AV delay timer. The AV delay timer continue until when it ends, there was no sensing of any intrinsic ventricular activity, so it pays. And at the post-ventricular atrial refractory period, at this point, there was sensing of the atrial activity, but it happens at the total atrial refractory period and also the post-ventricular atrial refractory period. So we say that this refractory period, if anything happened, there will be no response to those sense events. So no response happened. And it continues until at the end of the maximum track rate, which is supposed to have sensed another activity so that it will be able to act on it. Then it now senses another atrial activity here. And of course, the timer for the AV delay start, and then it elapses without intrinsic ventricular activity being sensed. Then it pays and the cycle continues. So this is what is termed the 2-to-1 block that is seen. And we can actually predict this upper rate behaviors since we said that it is the total atrial refractory period and the maximum track rates are usually what affects it. If we want to program our pacemaker, we look at the duration, the AV delay, we add it to the pVAT, will give us the total atrial refractory period. And if we divide this by our basal rate is given as 60 beat per minute. So we have to convert it to milliseconds. So that will be 60,000 beat per millisecond. So if we divide that by 500, which is the total atrial refractory period, it will give us 120. And 120 is closer to our maximum track rate. So a rate closer to this track rate, if we have set our device with these parameters, we know that if the intrinsic heart rate approaches 120 beat per minute, then we're likely going to experience a 2-to-1 block upper rate behavior in this pacemaker. Likewise, for Wakenberg, we do the calculation, we can be able to determine it. So, but for the pacemaker-mediated tachycardia, I don't know, this is not a complete one, but let me just try and explain it with this. Ideally, we have normal atrial cells, or atrial pace, ventricular pace. The timers are going normally. Then a PVC now occurred or happened somewhere here. Once the PVC now, let me find it. Once the PVC now occurred in between the maximum track rate and the post-ventricular atrial repolarization period, it will, and it's transmitted retrogradely into the atrium. The atrium will now sense it as intrinsic activity. And because it is a ventricular contraction that is being sensed by the atrium as the atrial intrinsic beat, the AV timer will not be sensed, or rather will not be stimulated. And also the pivot and the maximum track rate, they will all be blinded because of that PVC. So once that happens, you now have an established loop that an atrium will be sensed. Then it will try to set an AV delay, but of course, since the stimulus was actually coming from the ventricle before it was transmitted retrogradely, the ventricle will depolarize again and send the retrograde impulse back to the atrium, and the atrium will now sense it and stimulate the AV delay. Then the impulse goes to the ventricle and it continues. This loops, or rather this cycle continue unabated, and this will give rise to the inappropriate pacemaker tachycardia that mediated tachycardia that you usually see in some patients. And to cut this loop, or to prevent this loop, one will have to increase this pivot, increase the length of this pivot, so that all these free areas that are that can actually stimulate, or rather can allow an impulse to be a generated or transmitted impulse from whatever source to be sensed will be blinded, so that there won't be any sensing of any PVC by the atrium or the ventricle. So either atrial PVC or a ventricular PVC cannot be sensed. So if the pivot is increased, that will be corrected. So another timer that I usually set at the rest response setting, and it is used in patients with chronotropic incompetent, and these sensors that are used in pacemakers are the accelerometer, which detect motion, and the minute ventilation, which are usually piezoelectric materials. And these detect changes in the patient's breathing. That's the breathing movement of the patient. So the pacemaker sense, for the rate response, the pacemaker sense motion of the body where the pacemaker is inserted, or the breathing movement of the patient on the chest by the chest wall. So once the pacemaker senses it, that is increasing, it sends that signal to an algorithm within the sensor, which then analyze it and determine how fast the pacemaker should pace. So, and that will continue depending on the frequency of the vibration that the pacemaker is sensing. So at times we can have a problem with this, in the sense that since this accelerometer senses vibration, the person can actually not be in any exertion position, or may not be even having any activity, sitting down in a car that is vibrating, or somewhere that there's external vibrations. And then this material, or rather this sensor, can detect those vibrations as intrinsic as the patient's own body activity, and send those signals to this algorithm, which will now analyze it and start setting a new pacemaker rate. So if that happens, we now have unnecessary or unnecessary increase in heart rate in an individual that is sitting without doing any exertion. So also these accelerometers can actually sense rate, increase in rate within the ventricle or the atrium, and will reset the pacemaker basal rate, or rather maximum track rate, to a pacemaker to a new rate. And this rate that is usually the new rate that is usually produced can go very, very high. So in order to reduce this, there is another timer that is embedded within the pacemaker, those that have DDR and VIR and AAIR, in order to place the pacemaker in a position that no matter how much vibration the sensor has sensed, it cannot pace beyond this particular set rate. And this particular set rate is called maximum sensor rate. So it is the maximum rate that the pacemaker is allowed to pace at in response to whatever the rate response sensor are indicating. So it never can set above that. So now let's come to pacemaker modes. The current pacemaker mode that is being used is actually the NBG pacemaker mode, which is the North American Society for Pacing and Electrophysiology, and British Pacing and Electrophysiology Group Generics, which is termed the MBG. The N means the the NASP, that's the North American Society for Pace and Electrophysiology, the B, the BPEG, and the G, the generic, which is the NBG pacing. And this pacing system use positions and letters to indicate where the pacemaker is, and also the activity that is taking place, and also the response, and also there's rate modulation. So the first letter, the first number actually is indicating the chamber that is being paced. So it could be O, and O there's none. It could be A, that's the atrium is being paced, or V, which is the ventricle, or D, which is the dual, that's both atrium and ventricle. The second position is the chamber that is sensed. It can O for none, A for atrium, V for ventricle, D for dual. And the third is the response to sensing, which can be none for O, and T for triggered activity, or I for inhibited, then D for dual. It can also, the fourth position means rate modulation, and that is the R modulation. Then we have the fifth position, which is multi-site pacing, and these are how the pacing modes are arranged. So the pacing can be single chamber, just as I explained earlier. The single chamber pacing are VVI, AAI, VOO, and AOO. Then we have the dual chamber pacing, which can further be divided into tracking mode, which are the DDD and VDD. And we have the non-tracking, which is the DDI. That is, then we have the DOO. So in choosing pacemaker mode, we have to consider the cardiac output and the AV synchronization and the chronotropic incompetence in the patient. And this is what the European Society for Cardiology guideline stipulates that if we have a patient who has sinus node dysfunction, which is persistent, and there are chronotropic incompetent, the DDR and AAR persons should be used. Then if there are no chronotropic incompetence, DDD and AAI should be used. This AVM is AV node management, which are virtually in all of the DD modes, as I've explained earlier. So if the sinus node is dysfunction intermittent, we can use DDR, or with AV management, or DDR without AV management, or we can use AAIR. So for AV block, if it's persistent, we find out whether there's sinus node dysfunction. If there's associated sinus node dysfunction, these are the modes to use. If there are no sinus node dysfunction and no atrial fibrillation, these are the modes to use, the DDD, VDD, and VVIR. So if there's atrial fibrillation, the VVIR should be used. If the AV block is intermittent, the DD plus AVM should be used, or VVI if there's atrial fibrillation associated. So other settings are hysteresis, which is a mode that is used to minimize the need for pacing. This mode can allow the pacemaker to go or to drop below the basal level to see if the patient intrinsic cardiac activity can pick up. For instance, if the basal rate is at 60, then the pacemaker is expected to pace whenever the timer reach that 60 whenever the timer reach that 1000 millisecond. So however, with this hysteresis mode being activated, the pacemaker can even go below 50 without activating any pace activity. So in order to be able to see if the patient intrinsic cardiac activity can pick up, if that does not happen, then the hysteresis mode can be inactivated and the patient start pacing again. If that happens, if the patient had recovered, then it will continue. And this is usually done in order to assess for the intrinsic activity, and it also save the battery life. So mode switching can be activated, and this will allow for the pacemaker to change its setting from DDD to DD. Hello? Hello?
Please go ahead. We are listening.
Thank you.
I hope you are not sleeping. Or copy.
No, we are listening. Why are we?
Okay, the mode switching is actually activated in order to allow the pacemaker to change its setting when the need arises. For example, when there is atrial fibrillation for a patient that was on DD mode, can be switched over to DDI in order to prevent conduction of the fibrillary impulse to the ventricle, and that may lead to unusual ventricular tachycardia. Then there's a magnetic effect. This can be achieved by placing magnet on the pulse generator. And once that is sufficient enough, it can affect the functioning of the pacemaker by changing it to a asynchronous pacing mode. That is either AOO, VOO, and DOO. So usually, most of the times, if you have a pacemaker that is causing problem because of the settings, maybe it's causing waking back and 2-to-1 block or pacemaker mediated tachycardia, that you don't have a programmer to reset the pacemaker. You can use a magnet, place a magnet on the pulse generator, and it will revert the pacemaker to this modes, to the DOO mode. And there's another one, we call it the cardiac resynchronization therapy. Actually, in this, it requires about 3 leads. That's an additional lead to the other pacemakers that were described. And it can be equipped with a defibrillator in some cases, where the patient, if the patient was on a defibrillator and require a pacemaker, instead of and have some indication for sorry, and require a pacemaker, it is advisable that you change it to a CRTD than to put, sorry, yes, a CRTD than to put a defibrillator. Then, if the patient have heart failure, for instance, or cardiac decompensation, and require a CRT, or require a pacemaker, irrespective of the stage of the irrespective of the stage of the heart failure. If the ejection fraction is less than 40, it is advisable that you put a CRTP because the patient may eventually need a CRP. So rather than start the patient on a pacemaker before changing, so it is advisable you put the patient on a CRTP. So indication for pacemaker insertion, the indications actually for person is determined by severity of bradycardia, that's symptoms, rather than etiology. And there are so many indications that have been advanced by different books. However, this one was taken from the European Society of European Cardiac Society for patient guideline. So every block is a class 1 indication. Even though that the death that occur in every block may be due to heart failure, which is as a result of reduced cardiac output, and sudden cardiac death due to prolonged asystole bradycardia, as will be triggered by ventricular arrhythmias. In pacemaker, there haven't been any formal randomized controlled trial for person in every block, actually. Most of these studies that are done on every block are observational. However, they have shown a clear prevention of recurrence of syncope and improvement of survival in adults and in children. So that's why pacemaker is used. In the first and second degree type 1 AV block with prolongation of PR interval, with uncontrolled, there are uncontrolled trials which have suggested the symptomatic and functional improvement with normalization of the PR interval with dual chamber pacing have been noted in this individual. So those with sinus node dysfunction, there hasn't been any evidence that showed that cardiac pacing prolongs survival in patients with sinus node dysfunction, even though the total survival and risk of sudden cardiac death of patients with sick sinus syndrome, irrespective of symptoms, are similar to that of general population. Systemic thromboembolism and incidence of atrial fibrillation is common in both on-pace and pace individuals. So there was no comparison in this particular study, observational study. There was no comparison of embolic event between pace versus on-pace individual. However, in a review study, embolism in patients with VVI pacemaker was not different between the pace versus on-pace patient. So in a review of a large randomized trial by the Dennis, the study that was carried out in Denmark, comparing the single chamber versus dual chamber pacing. Stroke and atrial fibrillation was less in those with that has atrial-based pacing, or or that is AAI or dual or DDD, compared with ventricular pacing, compared with those with only that has ventricular pacing, that's VVI, and more in patients with sinus. Sorry, this was seen more with patients with sinus node dysfunction. So the patient that have AAIR person was associated with higher incidence of paroxysmal arrhythmias and twofold increase in pacemaker reoperation from fibrillation and AV block than the DDR. So that is why people with sinus node dysfunction are actually usually advised that the DDR the DDR pace mode should be a first consideration, must be considered in them. Sorry, it's recommended in them. So person for conducting system disorder without atrioventricular block, in patients with unexplained syncope and bifascicular block, that is, a pacemaker is indicated in the presence of either baseline, his ventricular interval of greater than 70 milliseconds, second or third degree intra or infrahissam block during incremental atrial pacing when we are doing EP studies. So patient is indicated also in patient with alternating bundle branch block with or without symptoms, because it has been suggested that patient with intermittent bundle branch block, it could be that actually they have a complete heart block, but it is just that one of the ventricle, may act as the escape source of the rhythm, and before you know it, the other ventricle has taken over as the source of the escape rhythm. So as a result of that, if patient come with alternating bundle branch block, it's an indication for pacemaker. So patient may also be considered in selected patients with unexplained syncope and bifascicular block, even if there has not been electrophysiologic studies, more especially those that are elderly, frail, or high risk and or recurrent syncope in them, because if you allow an elderly man that is having recurrent symptoms, syncope, he may develop subdural hematoma before you know it, due to the recurrent fall. So pacing is not recommended, however, in patients for asymptomatic bundle branch block or fascicular block. These are indications for cardiac synchronization therapy. It is recommended that patients who have left ventricular ejection fraction of less than 35 and a QRS duration of greater than 150 with LBB morphology, despite optimal medical therapy, should have a pacemaker insertion. And pacemaker can also be considered if the QRS duration is from 130 to 149, and the patient still have LBB. And other consideration are that the patient who received conventional pacemaker or an ICD and who subsequently developed heart failure with left ventricular ejection fraction less than 35% despite optimal medical therapy, and who have a significant prolongation of the right ventricular pacing should be considered for upgrade to cardiac synchronization therapy. And these are other indications. So the procedure for pacemaker insertion, as we all know, the pacemaker insertion needs to be implanted in an electrophysiology lab or a or in the cath lab, because we need the a C-arm fluoroscope to be able to guide the insertion of the leads and determine the position of the leads in the heart and in the right heart chambers. So the procedure is actually I don't know. I don't think it may be necessary for this discussion because it takes time. So these are the complications.
Hello, sorry,
Hello?
the procedure is very important too.
Okay. Well, let me discuss the procedure briefly. The procedure requires that the patient be explained to what is actually about to be done, and the symptoms and the indication for the insertion must have actually been made using any of the guidelines. Once that is determined and you have found a suitable patient, the insertion or the procedure is to be done in a cath lab, as I say, or an electrophysiology lab. For the transvenous pacing, for permanent pace, for transvenous permanent pacemaker, but for transcutaneous pacemaker, it can be done at the site of the bed, or sorry, at the bed, by the bedside using a defibrillator machine. The leads will be connected, the part will be connected. Usually the parts are connected. One of the part will be connected at the right subclavicular area, and then the other lead will be attached around the area where around the area of the apex of the heart, and the pacemaker knob will be set. The pacer node will be set on the defibrillator machine, and the necessary setting will be entered, and the person can start. That is usually it's not very difficult. The one that require being done in the cath lab is the transvenous insertions, where you need to monitor and see the position of the leads using the C-arm CT scan machine. And in doing that, the patient is positioned, and the site of the insertion is identified and clean and draped. Why I say identified is that you can use you can use the internal jugular vein. You can use a brachial vein. You can use a femoral vein, or you can use a cephalic vein, or you can use a oh my God. So the site identified, local anesthesia will be infiltrated at the site. So after cleaning and draping of the area, and then you advance a puncture needle using the Seldinger technique method. And once you establish that you are in the position, a guard wire is used to guide to stabilize or to guide the position of the dilator. Then a dilator will be advanced to dilate the place, a venous sheath deployed, and the pacemaker lead will be inserted. Once the pacemaker is inserted, if it's a subclavicular vein that is used, you try to identify an area very close to the point where the lead were inserted and create a pocket. And that pocket can be created in such a way that the pocket will be as deep to reach the pectoralis muscle, so as when you are tying the implantable pacer device, you have to tie it to the pectoralis major muscle in order to prevent its dislodgement. So that will be in position after insertion, and it will be sutured back in layer. The implantable pulse device will be sutured in layer, and the skin will be closed. It is advisable, or it is recommended, that during suturing of the implantable pulse generator, that you should use a non-absorbable suture like nylon, so as not to dislodge with time. And that will be in position for as long as the patient, the battery life takes. So if it's for temporary pacing, as soon as the transvenous catheter are inserted, if it's subclavian veins, you will connect the connectors to the temporary pacer or pacemaker machine, and continue to monitor the patient, because it's usually a temporary kind of insertion. So once that is done, you are done with the procedure, you've closed. You have to advise the patient and give the patient some instruction that they shouldn't, for permanent pacemaker, that they shouldn't manipulate the pacemaker with their hand or by frequent lifting up of their arm. So complications may those are the after those instructions, you need to do post-implantation assessment. And in the post-implantation assessment, you have to place an interrogator machine on the pacemaker device to see if those programs you intact are still intact, and as well you do an ECG and do X-ray to confirm the positioning of the leads. And once those are confirmed to be there, you ask the patient to come back after a month, and then subsequently you monitor. You see the patient next after 3 months, then 6 monthly, or from 6 months to 12 monthly, until when the battery life is exhausted, then you substitute it and put another one. So this is brief what I can say about the procedure. Then the complication that can arise following this procedure are things like infection, bleeding, pain, muscle stimulation, diaphragmatic stimulation, pneumothorax, because during the procedure, the lung may be punctured, ectopic bead vascular injury, venous thrombosis, cardiac tamponade, maybe during screwing of the pacemaker the pacemaker lead for active pacemaker lead. During the screwing, you may puncture the wall of the right ventricle or the right atrium, and that may lead to bleeding, which may result in cardiac tamponade or hemopericardium. There may be hemothorax when the veins are advertently damaged in the course of introduction of the pacemaker lead or during the procedure. Right ventricular avulsion, right ventricular perforation of other organs like the liver, stomach, diaphragm, and lungs. But for epicardial person, actually, that one, the procedure is usually done intra-op in patients who are undergoing cardiac surgery and are found that they need a pacemaker device. Or it can also be done in individuals who we cannot actually access, we cannot have access to the position where we want to implant the leads. For instance, for individuals who have tricuspid atresia, for instance, and other complex cardiac malformation, it is advisable that you do epicardial person for them, or if we implant an epicardial lead for them. And also those who have infective endocarditis and require pacemaker, it is advisable that an epicardial lead should be placed for them. So this are actually.
Mr. President, sir, is it possible? We're almost 11 o'clock. I don't know if we can round up, sir.
Okay. So, patient.
Oh, we have how many slides more?
I have said that one. So, interpretation of pacemaker ECG. This is actually the meat of the matter. And usually in interpreting a pacemaker ECG, you look at the stimulation artifact base rate. Usually, it's usually set at 60 beats per minute. So you count it and you look at the P waves. Usually, and the P wave will usually look like those of normal sinus rhythm because the leads are for the atrium are usually placed at the atrial ceiling, that's around the atrial appendix. So the impulse is transmitted like the one that is obtainable during sinus rhythm. So the other thing we look out for is the QRS complex, which will show a left bundle branch morphology, except when we have lead misplacement. For instance, in individuals that have ASD or VSD, the lead of pattern foramen ovale, the lead may cross into the left ventricle and the stimulation may be coming from that side. So with the exception of that, a left bundle branch morphology should be expected in an ECG lead of someone who has pacemaker inserted on the right side of the heart. And the QRS complex duration is usually greater than 120 milliseconds. In biventricular patients, the stimulation artifact before the QRS complex are usually 2. And the QRS duration is usually less than 130. For patient who you expect that they may have myocardial infarction, atrial patient will atrial person may not usually does not affect the QRS complex and the ST segment and as such, it may not, we may interpret the ECG as that that is done for normal for normal individual without pacemaker. So for ventricular pacing, however, there is wide QRS complex with large bundle branch morphology and a secondary ST segment changes. Hence, to assess for MI, one of the following approach may be used. And the approach may be that we inactivate the pacemaker and reassess the ECG to see. And this is usually risky because the patient who have symptomatic bradycardia and is having a pacemaker, which is helping him out. If you inactivate the pacemaker, he may develop symptoms and may even go into ventricular arrhythmias. So, and also the drawback here is that even after stopping pacemaker, there may be cardiac T-wave memory. That's the T-wave abnormal. The ST T-wave changes may persist for days after inactivation of the pacemaker because of this cardiac T-wave memory. So we can also compare the ECG with previous ECG and see if there are new changes which may suggest ongoing ischemia, or we can use the Garbosa criteria to interpret the ECG. So these are some ECGs of person ECG. Usually, if you have a pacemaker, is ECG. For a bipolar person, you may not be able to appreciate the pacemaker artifact. So it is advisable that you go to lead V2. And lead V2, you'll be able to appreciate the pacemaker artifact very well for because V1 and V2 are right. They look more at the right side of the heart. So if you may be able to see what it is inserted there very well. So you try and look at the P wave and count the base rate. For this patient, the base rate is 1, 2, 3, 4, 5, around 60 beats per minute. And you look at the P wave. There is a P wave, but the P wave is occurring after the QRS complexes. And of course, there seems to be a pacemaker also that the pacemaker spike that happens there. So you have a pacemaker here also and before the QRS complex. So in this individual is having a dual chamber pacing. However, the ventricle is paced before the atrium. So we have reversal of pacing mode here. So this one is for, if you look at this ECG, we can count the base rate from here. I think this is 1, 2, 3, 4, about 70, 80. And then you see the pacemaker spikes. There's one before the atrial depolarization and one before the ventricular depolarization. As we go, we'll see that there's progressive shortening of this of this RR interval. This is increasing in rate, and this is a typical pacemaker seen in patients who have respond activated. If they are if they have a V, this individual likely have a DDDR. That is what is giving this progressive length shortening of the RR interval because the patient is trying to sense an increase in the ventricular activity. So this one is a pacemaker for let me just look for interested ones. So this is another one. We see a pacemaker spikes occurring at regular interval, but however, is not preceded by.
Mr. President, sir.
Yes, sir.
Mr. President, sir. What about if we continue tomorrow? Because this is interesting part of the discourse. If we rush it now, it may really will lose the meat of the matter also.
I think I agree with you.
I think this is where the meat is. We can continue with this one tomorrow. This is a discussion that we have to break into two. I mean, what do we agree, class? Because I think so. Hello? Nope. I hope everyone has not slept.
Yeah, I agree with that. Continue tomorrow.
Okay. I think we should continue tomorrow. If Prof can bring endomyocardial biopsy procedure, he can bring pacemaker procedure in oral. So I believe that by tomorrow again, the President will have a brief on the recap on that. And then this whole definition of pacemaker stuff. Oh, Mr. President, what do you think? Let's get your own opinion.
No,
do you think you can finish up?
It depends on what the House decide because it's still remaining actually. I still have some information to let out on this case because you put two things or even three things together: the pacemaker malfunction and their management.
No, boy, I never knew this thing.
Hello.
Wow. Yeah.
Yes, Okopi. You know, on hindsight, we should have actually divided this into two presentations because these are three huge documents that we're trying to summarize. Because the procedure on itself has a whole document, the system and its setting has a whole document, and then you come to the clinical indications. You know, so there's a lot. There's a lot.
Okay. Maybe we will have to leave this tomorrow.
It's okay.
And the procedure, I think we need a procedure.
Well, you see, the procedure too is not a straightforward thing. Just like Conte says, it should be another topic on its own because see, the truth is, the pacemaker insertion, the procedure, the permanent pacemaker, if we're using the implantable permanent pacemaker, the procedure may be different from if you are using epicardial pacing or if you are using the transcutaneous. So they have different ways to approach them. That's why I look at it. If I was to put the procedure down, this is like 400.
Today we actually have two powerful presentations. These are the most detailed presentation I've seen in a very long while.
I think you can break the presentation into different slides. It won't be too cumbersome. Just as suggested,
maybe
you can break it into 2 or 3 presentations.
Yeah, so that we can take it from now till Monday, sir. Even if it is till Monday, we don't mind because this has a lot.
Okay, let's see what we can do, because I don't think in the exam they will just put pacemaker blank like that. They will tailor it to either implantable pacemakers, because if they put it even at that, it has to be a transvenous implantable pacemaker. If it's just pacemaker like that, you won't be able to finish it within that short time.
I think they may ask us either of them, either transvenous or pericardial or transcutaneous. But at least we should be able to do 1 or 2 procedures.
Yes,
because
I think the exams in was it April last year? Yes, they had a station on pacemaker. One of my bosses was privileged to be in that station. So in that station, when you get there, the first thing they ask you was the types, to talk about the transvenous, transcutaneous, and then epicardial. And then after that, they take you to permanent pacing and go through the indications, the different indications for pacing, and then down to CRT. When CRT is indicated, what are the indications, peculiarities, and so it was a station on its own.
Yes. So what I'm suggesting is this presentation by Mr. President is very large, and I sense that a couple of us may not have followed through. So rather than just jump and say tomorrow he should start interpretation, what about if we take a little bit step back and do one part of the presentation as a whole and stop? Monday we take interpretation and stop. It may help us, because I perceive, if not for the fact that I have a little bit of pacemaker training in Medtronics, I don't think I would have followed what Mr. President was saying. So he may need, if it comes to explanation, he's very good. In fact, that's why I say he's a professor of the PR segment of the ECG. So I don't know if we can give him that time. Maybe that procedure. I'm suspecting that Prof may bring one bizarre procedure for us, because there will definitely be a procedure. Since he brought endomyocardial biopsy that people were not expecting, he might come and say, because I learned from the recent updates. I think Dr. Conte, you're there, are you? Dr. Professor Okealam took heart failure, right?
Yeah.
Okay. So that means we need to take this heart transplant. That's one of his residents say we should focus on advanced device management of heart failure. Okay, so Mr. President, I don't know if you can help us tomorrow down to procedure. Then on Monday we can take this interpretation.
Okay, so we'll do the procedures tomorrow.
Yes.
Okay.
Even though I'm not going to be around.
So all the procedures, have you?
No, for pacemaker, not all the procedures in cardiology.
No, I mean, yeah, I know the procedures for the procedure for transvenous, it may not be the same with the epicardial.
Yeah. Yeah.
Yes. So, Dr. Gudia, what I'll advise, the epicardial pacing, we just need to have an idea. We won't be bothered much with that because that one, as you mentioned, is done by the surgeons. It's when they do open heart surgery.
Yeah.
But the transcutaneous and the transvenous, we should know the procedure. And for the transcutaneous, if you can lay hands on the ACLS material, because it's part of management of cardiac arrest due to bradycardia. So it is explaining those materials very well, and it's more practical. If you're able to lay hands on those, they can help. And then I think the European Rhythm Society, they have a document on the permanent transvenous pacing. It's not a long document. They have a document that explains the procedure step by step.
So, Dr. Conte, can you help us with the materials so that we can even give him time till Monday? It is too short a time.
Okay. I can be able to share the one for the transvenous. The ACLS material, I don't know where I can be able to access them in my system now. But I'll try and, but I'll send the one for the European consensus document for the transvenous permanent pacing. I'll send it now.
Okay, sir. Thank you so much. That we can give Mr. President some time then. Because actually I've been searching videos, searching materials for procedures on this pacemaker, and I've not found. So thank you so much, Mr. President. I'll call you again. So meanwhile, I want to thank Mr. President for taking out time for such a very beautiful, detailed presentation. Really, today has been a very beautiful day for this class. Two beautiful, detailed presentations to a point where we couldn't finish one. It has never been heard. This is massive. Thank you so much, sir. And thank you for everyone that has contributed to this class today. So we'll see how the presentation of pacemaker will continue either tomorrow or next week. Meanwhile, we should, if we, addition to the pacemaker, then we'll take it to Monday, and then we'll do past questions tomorrow. Dr. Jacqueline, any new information? And then please, Dr. Conte, you are in the
Hello? Hello?
breaking.
Copy, we stopped hearing at some point.
All right, I'm done. Dr. Jennifer, Jacqueline, if you have anything to add, I'm done.
No, we didn't hear you actually.
Yeah, you mentioned me, Okopi. I didn't hear what you say after that.
Okay, I said during the update course, please, if there are any specific things they're actually saying, you can break into the discussion and let us know so that we can check them up, or new information that we need to update ourselves, or where you think they are tilting their mind to. Please, we're going for the exam. You can give us those push.
Okay, absolutely.
All right. Thank you so much, everyone. Thank you so much, Dr. Augustine Odani. Thank you, Dr. Chief Gudia. Thank you, everyone. Please, let's have a nice night rest. Tomorrow we'll meet again.
All right, good night.
Good night, Chief Okopi, Onyeboeze, Godia, Conte. Thanks, everybody. Good night.